thanksgiving. This is the day that you have made. King of glory, be with us. Give us wisdom, give us understanding, revelation for this day. Thank you, God, that you have gathered us here with a purpose, and we pray that we meet it in Jesus' name.
Amen, and thank you very much. So welcome to today's session. So if we cooperate, we are likely to end this day early. Dr. Lazarus?
All right. Thank you so much, Kimosop. Good morning, everyone. Good morning. Good morning. My work today is to usher in two interesting presentations. These are the morning sessions just before our main opening plenary. So we have two presentations, one from CHS and another one from Kenya Red Cross Society. And I think as you listen to the presenters, you'll be able to interact with them and see some of the amazing work that they're doing. Next slide. Okay. So I'd like to introduce the first speaker, who is Dr. Clarice Ambale. She's a pharmacoepidemiologist and a health system strengthening expert with over 18 years experience. And she's currently working with the Center for Health Solutions, also known as CHS, as a health system strengthening expert. And she'll be here to speak to us. Let's welcome her on board. Tumkaribishe na makofi. Dr. Clarice is also a very active runner. She runs marathon, so ukijaribu kumkimbisha hata hatamfikia karibu, yeah? So tumkaribishe. Kindly go ahead.
Good morning. Good morning. Are we okay? All right. Thank you, Dr. Laz, for the kind introduction. I'm here to represent CHS, and I'll be sharing findings from a project we implemented on providing holistic care through an integrated service delivery model. We christened this project Vumbua. Vumbua is a Swahili word meaning discover. So we'll be walking the journey together to discover what the project attained. This project was a one-year project, a proof of concept, implemented by Center for Health Solutions Kenya for the past 1 year. We started in January 2025, and we completed the project in February 2026. 2 weeks ago, we stopped implementation, and we're now in the closeout steps of the project. So welcome to walk with me, the journey of Vumbua. We implemented this project in Kiambu County in 2 sub-counties, that is Thika sub-county and Limuru sub-county, in 22 health facilities, 17 of which were public health facilities. Out of these public health facilities, one was a prison, GOK prison health facility, and another one DOD facility. We also implemented the project in 3 faith-based facilities and in 3 private facilities. I don't know why the objectives are not visible. IT, kindly help me with the presentation. The objectives are not visible from the screen. So as we wait for the screen to be sorted out, we had a target population of men 25 to 54 years. We all know that the burden of TB is high in men in this age group. due to their hormonal composition and also their health-seeking behavior. So this was one of our target groups for this project. We also targeted children below 5 years and contacts of children with tuberculosis, and also adolescent boys and girls between the ages of 13 and 19. Adolescents are at an increasing risk of TB because of the changes in their immunity and also their expanding social networks as they join schools and also join the workplaces. We also targeted women caregivers in households with people having TB. We know that the burden of caregiving is mostly lying on women, and they're at a risk of getting infected with TB as they provide care. We also targeted people in congregate settings and informal settlements. The main objective of this study was to test and implement a comprehensive, innovative, sustainable, people-centered service delivery model in Thika County in the 2 sub-counties mentioned, with the aim of accelerating early detection, diagnosis, treatment, and overall management of TB and other respiratory diseases, including chronic obstructive pulmonary disease, asthma, and others. And we also focus on malnutrition, which is a risk factor for TB and also mental health. There's a bidirectional relationship between TB and mental health. People with mental health conditions are at a risk of getting TB because of their poor health-seeking behavior and poor adherence to treatment. They might have poor outcomes. People with TB are also at a risk of getting mental health issues because of depression and the challenges that TB presents to them. So I'll present to you our integration model. This is how we approach the project implementation. We had 2 tiers. Tier 1 was implementation at the community level. We had screening tools that were customized for use by community health promoters, simplified so that the CHPs can use them to screen for TB and other lung diseases and malnutrition and mental health. Our second tier was at the health facilities, mainly primary health facilities, dispensaries and health centers. However, we also implemented in higher level facilities like Thika Level 5 and Tigoni Sub-County Hospital. And we had 3 streams of screening for respiratory illness, for mental health illness, and for malnutrition. To help us implement this project, we developed facility tools, which included integrated screening tools for use at the facility level. For mental health, we had PHQ-9 to detect signs of depression and also GAD-7 to detect anxiety. And we also screened for substance abuse amongst our patients using the CAGE-AID for adults and CRAFT for adolescents. And we screened for TB, COPD, PTLD, and asthma. We also developed a facility screening summary register that was utilized at the facilities where we were implementing. And also developed a longitudinal treatment register for COPD, asthma, PTLD, and mental health. We know that for these conditions, we do not have a longitudinal register, despite many of them being chronic conditions. I don't know who's handling the slides. Kindly, the technical team. Okay. At the community, so for TB, we did not develop any tools because we already have tools for screening and for following up patients being managed for tuberculosis. So we utilized the existing tools. We customized the facility tools to be able to use them at the community for screening. And for the PHQ-9, we had just two questions that the community health promoters could use at households to screen for depression. For GAD, we had 2 questions instead of the 7 questions to screen for anxiety. And we also utilized the CAGE and CRAFT for screening for substance use among the households that the CHPs were visiting. And we had a screening section for TB, COPD, and PTLD and asthma that was comprehensive to screen for these conditions. We also developed a community screening summary register that was utilized by CHPs to summarize the findings at the community level. Our service delivery model was a one-stop shop. What were the approaches that we used to implement this project? One speaker yesterday mentioned that for us to implement a successful project, we need the buy-in of the leadership. So we started by engaging the county and sub-county leaders through county and sub-county entry meetings to get their support for implementing this project, and also to understand the gaps within Kiambu County in terms of integrated service delivery. We then conducted a baseline assessment to understand the challenges in implementing integrated service delivery model in Kiambu County, and so that we can be able to tailor our interventions to address this gap. The assessment was targeting to find out if we have any specialists within Kiambu County. Those are pulmonologists. If we had requisite equipment like digital X-ray machines, point of care ultrasound, spirometers, and peak flow meters. So from this baseline, we determined the gaps and were able to procure equipment and place them at the necessary points of service. We also did extensive capacity building of healthcare workers of all cadres, including community health promoters. The healthcare workers were trained in management of the 4 diseases of interest and were also given skills on utilizing the equipment that were placed in their facilities, including spirometers, peak flow meters, and point of care ultrasound. We also had an approach of task shifting. We utilized CHPs as linkage assistants to help patients to navigate the service delivery at their healthcare facilities, so that they're not lost to follow-up and are able to get to the points of service that they were referred to. And we also decentralized specialized services to these primary healthcare facilities through use of specialists that were roving to these facilities. We had physicians that were roving to the primary health facilities. We had nutritionists, mental health specialists, and also spirometry technicians that we had trained, and they could rove to the lower level facilities to deliver services to patients in these facilities without the patients having to move. We had innovations that we implemented. These included task shifting that I've mentioned, using CHPs, and also using clinicians and nurses to deliver specialized health services. Yesterday, Professor Afula told us the difference between task shifting and task dumping. Task dumping is assigning someone a task without capacity building them. We capacity build these nurses and clinical officers to be able to conduct spirometry, and they were roving to different facilities using the spirometer that we placed in those facilities, and they were able to do spirometry tests and diagnose COPD and asthma, and also monitor patients. I've already mentioned linkage assistance. We also engaged the private sector. We engaged pharmaceutical companies such as Cipla, with whom we collaborated to provide a spirometer at Thika level 5. We also engaged flower farms based in Thika to enable us to conduct screening within their premises. I've mentioned roving specialists whom we engaged and supported to move around their facilities to deliver specialized services. We placed the equipment we procured strategically to enable them to serve the entire 2 sub-counties. And most importantly, we provided integrated screening for multiple diseases that we were targeting. However, we faced some challenges during the implementation of this project. One being over-reliance on parallel programs. You know, the HIV program is running parallelly. As much as we are trying to integrate, there are some aspects that are running parallel. And also the TB program is still running parallel in terms of service delivery and also information system. Electronic medical records are not yet integrated, and in most of the facilities that we visited, we had to provide manual tools because the tools available, the electronic medical records available, do not capture COPD and other lung diseases, and we had to make sure that these are captured manually, which brought a burden of extra workload for the healthcare workers.
We all remember the stop work order that happened in January last year, which affected service delivery in most of the facilities where we were implementing, knowing that some of the healthcare workers were supported by these donors. And since we were not employing healthcare workers through this project, we were leveraging on existing healthcare workers. The project was mildly affected by these stop work orders. We were procuring a number of equipment, some of them which were being imported. There was a delay in this process as the shipment was occurring, shipment of the equipment, the accessories, and also the consumables, which led to a delay in implementation of the project by a few months. To conduct spirometry and differentiate COPD from asthma, you need to do a reversibility test and the need for bronchodilators. We faced a challenge in facilities where bronchodilators were not available to conduct reversibility testing, and hence were forced to allocate resources for these reversibility testing. We also had challenges in treatment and adherence, where patients were unable to buy medication that was prescribed by the specialists that we had engaged. As much as they were screened and diagnosed and prescribed for the right medication, these medicines were not available in most of the facilities and patients were not able to access them. Some patients were referred for investigation, like X-rays and CT scan, and they were not able to access them. They also missed appointments due to challenges in transport and other commitments. So I'll move straight to the case verse because of time. You heard the nice story about Mbua, but where are the findings? So the project reached a whopping 155,000 patients, out of whom 135,000 were screened. Majority were male, representing 62%. We had various streams, screening for TB, asthma, COPD, PTLD, mental health, and malnutrition. For TB, we presumed 11,997, out of whom 1,876 were diagnosed with TB and put on treatment. For asthma, we diagnosed 616 patients who were put on the appropriate treatment. And for COPD, we evaluated 522 and 110 were diagnosed with PTLD. 107 were put on treatment. Out of this 107, 91 were found to have 91 required pulmonary rehabilitation, and we are currently supporting pulmonary rehabilitation sessions for 35 of these patients. The sessions are ongoing despite the project having closed because patients need at least 6 to 8 sessions to recover from PTLD through pulmonary rehabilitation. We also diagnosed mental illness in 1577 patients, and they were put on treatment for counseling and psychotherapy, and also malnutrition. So we had some patient experiences that were shared, and you can read for yourself. So going to the lessons learned, I'll go straight to what can be scaled up. Integrated service delivery at all levels of service can be done, if possible, based on our experience in Mbua. Use of modern technology for diagnosis of lung health is important, and the need to support specialists to move to lower level facilities to offer specialized care, and need for strengthening health systems to optimize the use of resources. These are some of our impact results from January 2025 to February 2026. We reached 165,000 patients, and 135,000 were screened with the integrated tools that we developed. We boosted
case detection
in all the project sites by 31%. From 2028 to 2024 to 2033 in 2025. We identified significant non-TB health conditions during the screening, including PTLD, asthma, COPD, and mental
nutrition. This shows the growing importance of integrated care in real-world community setting. We delivered one-stop shop care through a team of mobile experts that I've mentioned, the roving physicians, spirometry technicians, mental health experts, and nutritionists. And we strengthened community-level health system resilience. We demonstrated a scalable, cost-efficient, and integrated screening model by providing more impact per dollar that is aligned with global priorities on person-centered care and reducing strain on facility-based services. We engage stakeholders, as you can see from the pictorials. We had a workshop led by the National TB Program and also the county government of Kiambu, and we engaged numerous CHPs through trainings and capacity building, and we collaborated with CIPLA. We were delivering a spirometer at Thika Level 5. Thank you so much for your attention.
Let's give another clap for Dr. Ambale. Thanks, Dr. Ambale, for sharing some key lessons learned using community to screen for TB and other conditions. So our next presenter is
Kauda Mohammed, who is well known to many of you. She's a public health and HIV prevention strategist. She's currently working at Kenya Red Cross, so she's head efforts to advance integrated people-centered health systems that focus on community-led approaches, service integration and scaling models, which include including PrEP. Karibu sana Kauda. Tupigie makofi Kauda.
Good morning, everyone. So my presentation today will focus on community at the center of their own care. And this is because it's in preparation to the community session that we'll be having today, because today the focus is community. So why are we saying that communities should be at the center of their own care? It's very important for us to appreciate that for us to build systems, we also need to involve communities. So this is how we build systems that are efficient, as well as equitable and responsive to the real needs. And the needs comes from the community. So just a bit of the background. People-centered integration emphasizes on the importance, and this is because the shift, we must have the shift. And the shift here is programs are not supposed to be vertical or horizontal. Yesterday, a speaker spoke about it. Programs must be diagonal. And what do you mean by diagonal? It means that this program must be people-focused. So by prioritizing local needs and perspective, we can create systems that are not only effective, but also resonate to the people they serve. Therefore, it's very important for us to have this integration agenda, but now people-focused. So what are we missing out if we do not have integration, or if we continue the way we are doing our programs? So some of the things that will be missing out, of course, so many services will be fragmented, and we all know that diseases don't come in fragmentation. By the time somebody comes to the health facility, they have come and they want to be treated and to be seen once and for all. So we'll have fragmentation, missed prevention opportunities, multiple service points, and inefficiencies, because you'll have to utilize resources to meet the same person at different times. So what is the reality? At community level, health is never experienced in silos. People come with multiple interconnection needs, such as HIV, TB, mental health. Access barriers are often deeply linked. So therefore, it's very important to address these needs collaboratively than addressing them in silos. So there is a lot of misunderstanding on integration, and of course different people are having their own definition on integration depending where you are. So fragmentation I mean, integration is not fragmentation. Care components working in isolation creates confusion. I know this might have worked previously, but then time has come that you really need to look at this. Multiple service points, where you have so many services, services split in different departments. Then, of course, like I've mentioned earlier on, misprevention, which brings about lack of coordination. I know there is misunderstanding that when we have co-located services or facilities, that means it is integration. So co-location alone is not integration. Referral alone is not also integration. Parallel programs under one roof are not integration. If the client experience remains fragmented, then integration has not been achieved. So that's just something we need to look at. So what defines integration? So number one, collaboration, where we build partnership and enhance community health outcomes. So this means we really have to bring on board communities. Accessibility, services where they are accessible to all. And sustainability, ensuring long-term solution. Community-centered integration starts with lived experiences. It is designed with communities, not just for communities. It ensures care is continuous, seamless, and responsive to the needs. This is not about simply adding more services. It is about redesigning systems so that they better work for the people intended to. So we really need to understand the client's journey for us to have proper integration. I've just taken an example of what happened in the recent past. One of the sites in Mombasa, that is Methadone site, was closed. And if this site had integration, then today clients will not be scattered everywhere. But because it's just a mat site, it does not offer other services. Closure means then the other services are affected, match is affected, and these clients have to move all over to get services from other areas. So for integration to work, we also need to anchor it along 3 pillars: community engagement, health system strengthening, and data-driven decision making. It is also important to emphasize that community-centered integration is not the right thing to do. It's not only the right thing to do, it is the smart thing to do it. It reduces duplication and optimizes limited resources, improves outcomes, and supports sustainable scale-up. So efficiency in integration, of course, there is a lot of efficiencies because you'll not be scattering resources everywhere. It also increases accessibility. When our client comes, they get all the services in one roof, and they are reached with all. So in terms of leadership, I'd really like to appreciate the Ministry of Health, NASCOP, for taking the bold step of aligning guidelines and SOP and programs towards integration.
This alignment with the Ministry of Health is not just a policy, it is a critical foundation of building community-centered health systems. The task before us is just how long we need to translate that foundation into a lived experience. So we need to empower how we shape community-centered health empower the community. We need to have collaborative strategy between the health system, community, and other stakeholders, and look at sustainable impact. Communities have an essential role in integration, and the role is to co-design the pattern and success of the integration agenda, co-deliver, that we have real effort and chance, because we have seen it. They are able to trust their effort. So roadmap to integration, we definitely need to invest in and allocate services, allocate resources, efficiently to strengthen community systems and community leadership in integration. We need to deliver, to implement the integrated agenda as much, and I'm happy that we really have this presented together on how to go about it. We need to foster leadership, development to give community services, so we really need to be empowered to be at the center and take the lead role on this together with all the other stakeholders, including management, and evaluate outcomes systematically to define strategies and improve impacts. For that, yes, we are committed to the integration agenda as part and parcel of stakeholders. For us, we have been looking at all our programs are community centered. Our community centered, and we will be more than happy to continuously engage with communities. So if we do not take this shift, of course there is lots of missing opportunities, such as communication, missed opportunities in prevention, in efficiency, but a lot of work and transformation. So centering community in care is very, very important. People are the heart of health systems. By prioritizing community engagement, we enforce care quality, improve access and foster trust. Ultimately, we lead to better health outcomes. So how does the future of integration look like? So integration is not about services. Integration is about people. Once we understand that, our approach changes completely. But if we continue just focusing on services, we might miss out on certain key areas. We commend the Ministry of Health and ASCO for taking the bold step in ensuring that as a country, all programs will not be alone, and we have evidence to give us that. So placing communities at the center transforms integration from concept to a lived reality. It makes systems more efficient, more equitable, and more impactful. If we want health systems that truly works, then we must ensure community are not at the edge of integration, but at its very center. Thank you very much.
Thank you so much, Lily, for sharing those perspectives from Kenya Red Cross. To begin a discussion for Canada. And that brings the end of our two presenters who are taking us through the morning session. And now, shortly we are transitioning to the main opening plenary of today. And it's my pleasure now to introduce So we have a very interesting opening session today. Go back one second.
All right. So
I would like to introduce Mr. John Balu, who is Assistant Secretary General for Programs at the Kenya Red Cross Society and the Director of the National Society Development and Localization Hub. Balu was with us during this summit. Kindly help me to welcome the stage as he takes over the next session. This is our main opening plenary today. Thank you so much.
Thank you very much.
Good morning.
Good morning, everybody. Thank you for the class. I started my morning very happy and upbeat about this very interesting session today. And the first person I met in this conference made the mistake of commenting on my outfit, and they told me that I have a very nice kaunda, and I'm still offended. I am seriously offended. So my first point will be to educate everybody else that this is not a kaunda. This is called a kaftan outfit, and no, your tailor cannot make one for you, because it is only me and President Pai from Senegal who has this particular one. So thank you very much. So I'm hoping we will not make that mistake again. But coming back to the session of today, session number 16. This summit was a body part. This particular session would be the heartbeat of this summit. It's the one that pumps meaning, pumps purpose, and very importantly, pumps reality in all these other technical sessions that we are having. And to be able to prosecute this, we have three very exciting speakers that will be here with us to prosecute the agenda of this session. And the first one needs no introduction. We are going to set the frame for this upcoming very interesting discussion that you do not want to miss. So please, ladies and gentlemen, help me welcome to the podium Dr. Bosire. Dr. Bosire is the Chief Executive Officer of the National Endemic Disease Control Council, and is a tutorial fellow. He's a fellow at the African Institute of Public Health Professionals, and his CV is quite long. It will take a very long time to be able to understand the role that he plays and the organization that he has, the role of being able to be at the backbone of HIV prevention and control. Dr. Bosire has also a very distinguished career in the academic field, having trained and mentored a lot of the public health professionals that are here today that continue to have an impact in this country. So please put your hands together for Dr. Bosire.
Thank you very much, Balu. Distinguished guests, our partners, both bilateral and multilateral. I can see my brother Brian here, I can see the UN Public here, communities in all their diversities, particularly communities of people living with HIV. Colleagues, ladies and gentlemen, as we welcome our PS for Medical Services, Dr. Umuruga, it's my pleasure to stand before you just to open up this session on this day of communities. I think strategically, this day was not put at the beginning of the summit. Neither was it put at the end of the summit. It was integrated in the summit. So this is an example of integrating communities in the discourse on integration in this country. So the framers, the organizers, and the backers of this program, thank you very much. Makofi kwao. Asante. And that includes the peer himself, that includes Dr. Mulwa, and the entire team of governments and actors for making it happen. Also, making my personal apologies for not being with you from Monday and yesterday, because we were involved. On Monday, I was in the PS in Nairobi. We were defending the budget for the health sector. Yesterday, I was appearing before the Parliamentary Investment Committee, where they were asking whether we spent your money, whether we used it well, and I can assure you they gave us a clean bill of health. They say we have a modified opinion, and we did well in terms of the utilization of the resources that were according to us, both from the public and the private and partner sectors. We have taken a very long time as a country in structuring our systems, in investing and strengthening supply chain systems, human resources for health, the building blocks, what matters, what works. However, for the community member, for the person who is seeking care, the experience often remains fragmented. The experience often has multiple views. The experience often has repeated steps and disconnected services. And often, stigma is actually inbuilt in that care process. So when we gather here, and when we talk about putting communities at the center, we want to understand from those who have experienced firsthand where the systems breakdown might happen and where they exist. When referrals and files are not working, when medicines are not available, when services don't connect, the first people who feel that pain point are the community members whom that system is supposed to protect rather than expose. So, being a community is a very important day for us to have a discourse, an open discussion as to how communities can be co-financed, can be co-implementers, and can be co-evaluators of a successful integrated health system. Last year, at the initial stages of the shock, due to the various software orders and the various the changing financing architecture, NSDCC deliberately reached out and did a rapid research initiative across the counties of this country with support from the Gates Foundation on what the impact of the very dynamic, rapidly changing financing architecture would mean to the delivery of health services. And I really want to thank the 70 world systems of governance because while it not for the rapid initiation of some form of service delivery by the county governments, then our system would have been at the brink of collapse last year. Were it not for that fast action that the county governments took. So we went around the process now, just asking ourselves, where on which are these system gaps, these structural exclusions, these programmatic weaknesses that leave certain populations, that leave certain populations, that leave certain geographical areas outside the effective reach of national responses against all the main diseases, HIV and other systemic diseases. And we classify our main areas of pain, what we call the blind points of integration about 5 years. Because counties were, they were trying to respond. They were trying to wake up and have a way of mitigating this impact that was so rapid that nobody understood that we as a country are going to put our heads together to really form one common agenda and one method or one solution of how we are going to solve it. Number one is how we implement implementation of integration and how it affects communities. If you look and you go across the counties and again across the facilities, we have tried as much as possible to integrate and bring services together. The question we got at the reality of the ground: does this integration enhance, increase stigma and discrimination, or does it reduce? There is evidence of certain outpatient facilities where we went to. Yes, there is integration that have enrolled within the same service block of outpatient. However, the clients who are seeking medication for their needs are sent to certain diagnostic, to certain classes room, to certain consultation room. So anyone who wants to consultation room, everybody can know and can tell that that's an HIV client. Clients can send to a certain pharmacy, and in that pharmacy, more than not, people are queuing, and people can see who is being given a dose of their needs and who is not. So as we do this integration, is it also coincides on the fact that the stigma and discrimination will perpetuate further alienation of communities from coming to seek services and therefore further aggravate the situations that we have. Number two, we realize that we do not have a common and shared definition and package of care for integration. Where does this integration begin? Is it integration just of HIV, TB, and STI? With non-communicable diseases? Is it out the outpatient? Is that the chronic care center? Or for the chronic services? Do we turn our comprehensive care centers into chronic care centers? Those are the questions that are not, that at that point were really disturbing the health practitioners and the community themselves, not understanding what the full meaning of this integration means to them. Number three, on the implementation side, we found out at that time healthcare workers were not well prepared for integration. Healthcare workers, because of the verticalized system, because people were managing TB alone, people were managing HIV alone, people were managing malaria alone, people were managing, there was no coherence in terms of the practical competence of integrating these three issues, or these more than three issues. So, as a result, there was a need of looking at the way the curriculum for healthcare workers at the pre-service and at the in-service level is currently structured, so that if integration really is going to be sustainable, then we can begin from that skills and capacity developing level, so that it's inculcated and it's long-lived. The other challenge that we found on the implementation perspective was how it affected the key populations. Yes, we appreciate that we shut down the dices for FSWs, some dices for MSMs were shut down. As we were bringing them to this center, to this one facility, there are certain dynamics and certain sensitivities that are faced by the key population that are only unique to them. So we must also be awake to that fact, that for us not to ostracize, not to discriminate against the key populations, we must address those key sensitivities that regard the issues of human rights, the issues of access, the issues of accepting the services that we're offering them, and the issues of embracing this integration discourse as we go along. Because if we go along and leave them behind, we do know the high prevalence that exists within the key populations and how it will eventually affect. The other issue of privacy and confidentiality, even at the community level, we are integrating. We are saying that the community actors, including the community health promoters, shall be responsible, shall be mandated also with the responsibility of linkage, with the responsibility of acting as intermediaries between the communities and the healthcare workers and the facility. Now, are all the community actors in a position to keep and maintain confidentiality, especially when it comes to matters, such sensitive matters such as HIV? When you send them to trace that expectant mother who is living with HIV, who did not come for the NC clinic, how confidential will this community health promoter be in terms of maintaining the level of privacy that client deserves? Because then if we do not, then that client might actually not come for service at all, or might even move from that local area. The other area that we found where there are blind spots that need to be addressed, and there are two speakers who will come after me. Dr. Menya will be talking about service delivery. When you talk about service delivery, is prevention adequately centered? The intersecting burdens of the other syndemics, Dr. Menya, that relate to the occurrence of new infections. We know these endemics. We know among the adolescents and young people, we have these intersecting vulnerabilities of new HIV infections, sexually transmitted infections, adolescent pregnancies, and gender-based violence. How is that addressed at the service delivery point? Comorbidities. You know, this community member is not, we are not responding to only one disease that is occurring on, among these community members. We are responding to syndemics, not single diseases. So how are we at the service delivery point going beyond the traditional disease that we're talking about in this room? Because in this room today, we have people who are 70 years living with HIV. We have people who are 75 years living with HIV. Those people now, they're talking about diabetes, they're talking about cancer, they're talking about hypertension, and you have discussed already. So at the service delivery point, how do we make sure that we are looking at this client from a person-centered perspective rather than a facility or service-centered perspective? The other issue, and this we noted, as society sometimes we forget about it, people with disabilities, as community members. How many of our facilities, as we talk about integration, have facilitative environments that can even make them come and seek services? How many have ramps? How many have very tight and tiny corridors where wheelchairs cannot move through? How many have assistive devices and technologies to help them move around the facility? How many packages of medicines have instructions that are friendly to people with disability? How many are written in Braille? Those are the questions. As we go forward, we must address at the service delivery perspective. We do not even know how many people are living with people with disability across the different disabilities as defined. We don't have a mapping so that we can know as we are planning to respond and as we are planning to support them. Then these are the plans that these are the bare minimums that we must have in place. We have talked about equity as a center, as a test of integration. In that facility, remember, when you look at almost the 4 typologies of KPs that we have, especially in this country, you look at the female sex workers, you look at the men who have sex with men, you look at people who inject drugs, you look at the transgender people. Almost all these groups are in some way conflicted with the law. So when these people are coming to seek services from a common area where the general population is seeking services, will they feel criminalized? Will they feel judged? Will they feel that they are actually exposing themselves to possible and potential harm? We have seen it. Mulu and I have gone across counties in this country where we are responding to calls for help from these key populations who are at some point, at some threat, under some threat, and at a point of danger. When they are going to seek services, they are actually judged and they're looked upon as criminals. We know that we are also leaving our children behind. Children are a population and a community to themselves. If you are talking about separation rates for HIV of 66% compared to the general public of 83%, how do we bring those children on board? How do we bring our adolescents and young people as a community on board? Because we are for sure witnessing unacceptable levels of new infections, especially for HIV, occurring amongst our adolescent young people. 41% of the new infections among adult population that occurred in 2024 occurred amongst those ones who are aged between 15 and 24. If you expand that bracket a little bit to 34 years, 15 to 34 years, they are accounted for almost 75% of the new HIV infections. And yet, this is the population that, ladies and gentlemen, does not relate with HIV as a virus and AIDS as a condition. These are the young people who were born after the 2000s. After we had a national treatment program that made us healthy, and anybody living with HIV looks like you, looks like me. So they cannot relate at all. So when you start telling them about HIV, they often tell me it's better to have HIV than to have cancer. They often tell me it's better to even, to have HIV than to conceive. Because for them, when they conceive and become pregnant, they are judged among their peers. But when you're living with HIV, nobody can tell that you're living with HIV. So this community, how do we make our services friendly? How do we make sure that we do not leave them behind? Because these are the future of the nation. They're the ones who are going to make us harness the demographic dividend for which a young generation, a young population should portend. Remembering that 59% of our population is under the age of 24 years. Now let me talk about also the community of men. Whereas 65% of the people living with HIV in this country today are male. Men, unfortunately, are dying more in terms of proportionality than women. And why are men dying more? Men are dying more because we are a community, we have our own practices as a community. Our practices are those ones of bad manners. We don't come for testing. I wait for my wife to be pregnant and I send her to the ANC. And once she comes back with a negative test, I go and meet my fellow men and I thumb my chest and say, I'm okay. I'm okay. And yet you are dying inside slowly because you are living in discordance. Men often have habits that expose ourselves in our groupings, in the way we relate with each other. Rarely have I ever had a fellow man come and tell me, I have a problem. My prostate has an issue. Not unless it's people whom we are very, very close with. But you find our wives, you find our sisters, there is nothing they don't share. There is nothing we don't share. As men, we have a saying that in Kiswahili, nitakufa kiume. I will die like a man. For sure you will die like a man. If you do not come if you do not come for testing, if we don't capture you early, you come too late, you have co-infection with the TB because of your manners also of interaction with fellow men, then you'll be dying. So we have to have a national discourse about men. Men and boys, as much as we have invested in girls and we have not reached there, we have not optimized that investment, but men and boys are being left behind. And we have to talk as a community of men and boys. Then the older people who are living with HIV. If integration does not work for the most vulnerable, then it does not work at all. The community is led by Davis and the colleagues who are above 70 years now. Who is going to care for those communities if the system cannot make sure that we also not only address their HIV status, their TB status, but we also address the non-communicable disease status. So the systems that we put in place for integration should address this. And then we have populations that have been left behind due to their geographies, due to where you were born. You were born in Mandera. You were born in Garissa. And unfortunately, because the presidential emergency plan for AIDS relief that was headed by brother here, Brian, did not have programs in that region, the country also did not put in place programs in that region. And the mothers who are getting pregnant today do not go for ANC because they do not know about the HIV virus. I'm not blaming the countries of Isiolo, the countries of Samburu, Baringo, Wajir, Marsabit, and Mandera, and Garissa, where mother-to-child transmission of the virus is above 20%, as opposed to the national one of 9.3%. I am not blaming them. I am blaming us. Because in the process of this planning, we never knew that we'll build roads that will reach those places. Have you heard about the road from Modogashe to, where does it go to? You know? If I want to go to Wajir today, I'll go to Wilson. I take a flight called iFly, and I'll be in Wajir within 1 hour, 30 minutes, or 20 minutes. If I want to go to Mandera today, 1 hour, 40 minutes, I'm in Mandera. If I want to go to Garissa, they have even closed the airport. Now they are constructing an international terminal. You know, fit for Dr. Gondi and the team. That's what they are doing in Garissa. So, movement of people has become commonplace. We have interacted with those ones of you who are coming from the northern frontier, whom hitherto were calling this virus a virus for Nywele Ngumu. The HIV virus is no longer a virus for Nywele Ngumu. It's at your doorsteps. And we must have systemic, intentional, and deliberate plans and programs of reaching out to those counties where we are seeing these ballooning cases of new HIV infections, especially among pregnant mothers and children. So that population also should not be left behind. Then the health systems, the blind spots within the health systems. The blind spots which, yes, we have invested in strengthening the health systems, but there are blind spots there. Donor dependency. How is it a threat to the communities? Last year taught us, it showed us, I don't have to belabor, and I'm sure it has been spoken about. Community data, invisibility of community data, so that the system is accountable to communities for our actions. Community-led monitoring, more often than not, does not get into the national systems. And yet community actors are the ones who will tell you which facility is non-functional, which facility is charging before you receive PHC services, which facility is being opened late for you as a CEC or a director at the county or a CASCO. It is the community actors. So community data is very critical, and we must get a way of having visibility and utilizing that community data as we go along. We must define the roles of the various community actors that we have. Be they community health promoters, be they the other community actors whom the system has invested in all through. The mentor mothers, the peer educators, the adherers, counselors. We must ensure that as we move forward, as we integrate this particular population, the services, the skills they have do not go down the drain. Also, integration in terms from a financial perspective, which is part of the health system building blocks. Integration of the needs for these people who are living with a myriad of conditions, including HIV, TB, and malaria. How have we included them into our SHA packages? And that's a conversation that is currently ongoing, and it's a conversation that is important for sustainability. There's another group of people that we often not forget, and we often sometimes leave behind. In this country, PS, 97%, actually 96% of Kenyans ascribe to a certain belief in a supreme being. 96%. 96% believe in Jesus. They either believe in one supreme being, God. They believe in Allah. The Hindus, they believe in some supreme being. So as they believe in some supreme being, As they go to the temple, what days do the Hindus go to the temple? Every day, yeah? Are there Hindus here? Okay. As the Hindus go to their temples, as the Muslims go to their mosques on Friday, as Seventh-day Adventists like me go to church on Saturday, and as the Catholics and the other Protestant congregations go to their churches on Sunday, within that group, we have 96% of Kenyans. So every week, 96% of Kenyans are meeting somewhere. 96% of Kenyans. So how can we utilize those opportunities that are provided to us by the faith sector, by the community and cultural systems to continue our discussion on integration? Because when they talk about HIV, when they talk about TB in their platforms, that's integration. When they talk about it from their pulpits, that is integration. In a nutshell, ladies and gentlemen, I'm saying we have work to do. We have serious decisions to make today. And the core messages from me is that communities must be drivers of design. Communities must be implementers of integration. Communities must be evaluators. They must be the group that defines what we want to see as success. Communities are not beneficiaries of our benevolence, but communities are core and key to the success of integration. We have made attempts at National Syndemic Disease Control Council, and we launched on December 1st, the Kenya AIDS Integration Strategic Framework. Is available to all of us. It is a platform from where we can begin, from where we can look at to continue building this conversation. Otherwise, it is your day as communities, and we are all communities in different diversities. God bless you, and I look forward to a very fruitful discussion. Asante sana.
Thank you very much, my brother, Dr. Douglas Bosire. Let's applaud him once more. That has been very passionate, very insightful, and lays the stage for the plenary session that is about to begin. However, I want to change the program a bit. We have an important visitor in our room. Say amen. We have an important visitor in our room. Say amen. I now want to call the Secretary Administration to take us through. We will change the program a bit to accommodate the Principal Secretary in the State Department of Medical Services, Dr. Auma Oluga, who has graciously joined us this morning, and we'll have a short session to give him an opportunity to speak to us. Asante.
Thank you, Dr. Munwa. So the visitor that Dr. Mulwa has alluded to, I'm sure, is none other than Dr. Luga, our Principal Secretary, who is our chief guest today. Good morning, everyone. My name is James Ntabo, Secretary Administration. And riding on protocols, allow me then to prepare the ground for our chief guest by inviting Dr. Ganda to integrate national government and counties in this context, and welcome, bring for us our chief speaker this morning, Dr. Omoluga, our beloved PS. Thank you. Karibisha Dr. Ganda, a good speaker. Thank you, Dr. Thank you.
Good morning, ladies and gentlemen. Fine, thank you very much. First of all, our PS, Dr. Omoluga, our dignitaries, all invited guests, colleagues from the counties, let me appreciate you for making it up to this far on the day 3 of a very tough session of thinking and discussing. I already gave my remarks yesterday. Today mine is very simple. But before I do what I'm supposed to do, let me say that if ever you are doing any reform and people are not uncomfortable with what you're doing, then you're probably not changing anything. So people must be uncomfortable. Emma Kofi, somebody's clapping over here. And so our PS and the Ministry of Health and our president are leading these reforms in this country and shaking the health sector, because you cannot do the things the same way that you did them and expect results. And for those of us who already saw what is going on, those reforms are already starting to have an impact on the ground. We talked yesterday about primary health care and what the reforms are doing in terms of primary health care. So let me take this opportunity, and it's now my honor and pleasure to welcome our guest today, PS Ouma Oluga from the Ministry of Medical Services. Let's do something special for him. Let's stand up and clap for him as he comes in to speak. A coffee. I see he's engaged in a very tough phone call. I hope he's not going to eat all this time. Karibu PS.
Please have your seats. I'm almost losing my speech. So thank you, Dr. Ganda, and thank you to our good teams. I could see the passion in Bosire. You know, we were speaking with Gerald whether Bosire has seen the room is so full and he wants to get some votes. Yeah, but there's no problem because that's also part of integration. It's a good morning, and I know you guys have been here. You've been here yesterday. You've been here Monday. The minister was already here. There's a lot that have been said, perhaps a lot more unsaid. And we've heard from the data, we've heard from the evidence. We've also heard from the lack of evidence. We've heard emotions, case studies. Maybe the scientists have also been speaking. People have been managing programs. The partners are here with us. They have given us a lot of perspective. I don't think that there's anyone in this room who is disagreeing with the integration. Is there such a person? Somebody who is a bit opposed to whether we should integrate or not? I suppose that person doesn't exist. And so I think that case is made. It's done, it's dusted. So perhaps what we should be talking about is when we are going to do it. There are a lot of models. There are people who think that they have already integrated. There are a number of counties who believe that, what are we talking about? We already achieved this some time back. But there are also so many people who have integrated, but they don't think they have. There are also some people who have done something that they think is integration, but perhaps it's not. So I think why we are here is to perhaps harmonize or agree on what this integration really is. And the most important thing after agreeing on what integration really is to leave Mombasa with one decision, that the things that have been stopping us do not stop us. So we perhaps should also talk about the things that have been stopping us. So what have stopped us from integrating? All these years that we've been discussing programs, transition, more than 15 years actually. It's not very new. Although there's something that has forced us to be here, and that is the funding cut. I believe Brian and Chai and the UNAIDS, if the money was still flowing, these guys would not be in this room. Or they would be in this room but discussing how to spend the money, not how to integrate. Yeah? So something has forced them here. Something has forced us to be here. And that's a very difficult conversation, although it's the awakening conversation. You know, yesterday, I don't know, Muya, are you here? Yeah, he sent me, yeah, Muya is there. He sent me this document from Global Fund, and I was just doing a bit of reflection on the 8th replenishment, which closed last year. And you know, the reality, which I'm sure has also been said, is that only $12.6 billion were realized out of a target of 18 billion. That's a shortfall of about 6 billion. All the big five, you know, in Kenya we have the big five, which are animals. But when it comes to money, there are also big five, which are countries. The US has reduced its pledge to the Global Fund by more than 1.4, France by around 58%. You saw Japan, the European Union. And so there's a lot of readjustments, and that's why you are here. So let's not pretend why we are here. We are not here because we love integration. We are not here because it's something so nice that we have to do, you know, this beautiful thing that has come and this is the way the health sector must run. No, none of you is here because of that. Most of you are here because you've been forced to it. It's sort of like an emergency, a crisis that you are trying to respond to. So if we agree on that, we can also move ahead very smoothly. If we disagree on that, then we'll argue on what integration means. And perhaps there is also a realization, there is still some hope. A lot of us who believe in faith, things unseen, feel like maybe the money will return. Just maybe the money will return. But there's no guarantee. So, you know, I have been privileged to be part of these engagements with our bilateral and multilateral partners. And the language has completely shifted, very much shifted. I'm particularly not very surprised because I have very deep-seated patriotism in me. So sometimes I also feel like we should be carrying our own weight, and we should push ourselves as much as possible to carry our own weight. Because why do we have that weight if we can't carry it? And so even as we go into these rooms, often for me, the idea is not to push as much to be financed. The idea is usually to find the priority, the catalytic point, where whatever little resources that the partnership and the development organizations put in the healthcare system produces self-reliance, produces that ability to carry our own weight of the health needs that Kenyans put on us. And so the question is no longer whether integration will happen. I have just mentioned it's happening. You like it, you don't like it, it's happening. And we can't stop it. I can't even stop it. It doesn't matter whether you make noise to the president, it doesn't matter what you do. It will happen. So the question is how you, as an individual, want to take part in it, and how we, as a collective, will design it. And that's why there's a lot of speeches here. Everyone with their own ideas, data or service delivery there, people-centered, not facility, communities should not be forgotten, All of us are dancing on the stage, so that perhaps somebody will identify who danced better than the other one. Unfortunately, all of our dance must form one orchestra. All of it. All of it together. And, collective designs are not easy. Sometimes they are driven more by consensus than what is evidence-based. Because many people can also be wrong. True or false? We can come out with very nice resolutions out of this integration. Beautifully written. And it has happened before. And we are all wrong. It doesn't work. Then we come here 12 months later to discuss why it's not working. And most of the time, we will not point at ourselves. We will point at somebody else. We'll try and find reasons why it didn't work. And that's the thought that disturbs me the most. Whether everything we discuss here becomes action, and whether that action moves us to the integrated system that we want to create. And perhaps not just the one that we want to create, but the one that actually works. Works on prevention, the one that works on the care, the continuity, and one that integrates with our finances, relieves the burden, of all of these financial shocks that we have, and is realistic enough for the burden of NCDs that we are grappling with, the challenges of the other issues. And so, with all of those ideas that we have, whether they are fragmented or whether they are beautifully woven together, the question is, what action are we leaving this room with? And the question is, where is that integrator? Because if we talk about integration, something must glue people. I hope I'm making sense. So where is that integrator? Have we identified it? What is this thing that is connecting all of us together? Or we're just talking about integration without figuring out the integrator? And that's what we should spend most of our time discussing. What is it that is going to glue these services that we're running in vertical programs? Where is that point? Because without discussing the integrator, every integration effort will fall flat. I know this room might be having a lot of clinicians, people who give care. You know, I was privileged to work in a hospital, Vihiga. I used to run the HIV clinic. And I also was the one in charge of the inpatient, the medical ward. And so I would go to the HIV clinic, but I would also come and do ward rounds. And those two worlds were very different. So in 2013, we tried to come up with some model where, you know, and I've given this story before, I think when I was talking to some guys at the Syndemics. You find a young girl, 8 years old. She comes, she's on ART. She lives with her grandmother because her parents are long passed on to glory. She has had meningitis, and so she's also having some convulsions post-treatment. And so she has to go for a pediatric outpatient clinic. And then come and take her ARVs. And then occasionally, she has to go for other reviews, including by the surgical teams. 8-year-old, she barely knows what to do. She barely can take instructions. Her grandmother has a lot of other children at home to feed. And then you start to see how a healthcare system can be unfair and how a healthcare system can be blind. But how all of us are not blind, because when you are in that HIV clinic, you just see the 8-year-old and you may be doing your best to attend to her. But you don't see the other journeys she takes. You don't see the issues at home, the poverty, the fact that even that morning, it's the chief who perhaps reminded them to come to the hospital. Because you are in this chamber where you're doing everything as per book, expert level, but very blind to the outside world. And as I think about the integrator, for me, is what is it that can make all of us view the entire picture? Because without viewing the entire picture, many of us will think that you're right. I will come and speak about the Social Health Authority and the benefit package and the financing framework that we have, the domestic resource mobilization. Then I'll stand my ground and tell you the government has decided this is the route, but I'll not see what's going on the other side. So what is it that will give us the full visibility? Because that's where we find integration, the full visibility. That full visibility. That's where we find the integration. That's where we find the entry point to creating one system. That links all of us, that registers all of our actions, and that makes our reporting true. And perhaps that's where this summit should also spend its time, in looking at some work that is going to make us view the entire system. In summits like this, representatives from various groups, communities, patient advocates, may feel the urge to advocate, to do what I used to do best. Yeah, I can see Kamau is already doing like this. We used to with him, we still are comrades, comrades. The urge to bring the voices very passionately and to push some more for somebody else to do the work of integration in a way that responds to them. But I think the flip is that we want you to do that work. We want you to participate in this design so that instead of being at cross purposes, like we are talking at each other, we just want to take your suggestions and apply it against this integrator, the thing that views the entire system, and see whether it works or it doesn't. So that you also see whether it works or it doesn't. And then we make the decisions as we move forward. And I believe that from the community health units all the way to our policy, governance, and leadership, we must all find this single purpose of integration. And that should be the standard. Now, it's not as easy as I'm making it sound, because there's a lot of disruption in between that will come. That disruption may also lead to some disagreements, which is okay, because I mentioned that we are in an emergency. We are not here because we love each other. We are not here because we want to be here. We are here because the money is not there. I know that part you don't want to listen to. But I am a truthful man. I'm a truthful man, but don't look at my ears. So, and being a truthful man in charge of implementation of budgets, I have to be extremely candid with you. And I have to keep repeating that the money is not there. So we have to figure out what we do without the money. And sometimes we don't need the money as much, although Brian should not hear that. And so the two options that we have is to live here with a good communication of what we've done. Very good communication. Mulu, are you preparing a communique? You're preparing a communique, yeah. Very good communication, beautifully worded, broadly endorsed. The entire team is here. And then we go out there and then start to wonder, okay, so this communication, who is going to do what? Where? How? How will we even know that the things we've discussed are being done? Then 12 months later, we are wondering why the things we discussed are not happening. And so even as we live here with very good communication, I want us to live here with option number 2. which is very individual, a decision. A commitment to one integration action. I don't know, you've spent 2 days, so I don't know whether, today is mid of the summit. I don't know whether we are getting closer. I have to confess that having not been here for the last 2 days, I can't confess that I know how we are shaping that integration action. But I hope that beyond the communication, we leave here with a decision. That one action, uncomfortable as it is, because we are all forced to do it, because there's no money. And that action should be very specific and should allocate responsibilities to all of us. But it should also be disruptive. We shouldn't live here with some level of comfort. No, we like to do things in some level of comfort, some smoothness of how we are going to do things. And because of my background, which Kamau knows very well, we like things that just start. And we are very privileged that even our president just likes things that start. So you don't talk so much, you just do. And we all should do. So I think this architecture of integration exists. Recently, we brought partners together and we spoke not just about integration at the facility level or at the community level, but really at the policy level. Really at the policy level. And for me, the architecture that we are building on the health policy platform that enables us to have visibility of what everyone is doing, that gives us a pathway, whether you are from the community or from the hospital, that enables us to prioritize the actions that give us the most results, that enables us to channel the money alongside the strategic interventions that we've aligned as government, that facilitates innovation and facilitates inclusion of all of the ideas, so that people don't feel that I am not AMREF, I may not access the PS, or I am not CHAI, that wherever I am in my small corner in Kilifi, if I have a good idea, it will find its place at the top, and it may become the game changer for this country. I place that as the integrator. This platform that we already established, that our participation in it, our strengthening of the structure that we have discussed, of the pillars. Because as we discuss the challenges we are having with the HIV response and how we want to move forward with the shifts in financing, with the shifts in technology, with the shifts in the science, we also have other challenges. We have challenges of maternal and newborn health. Next week is an international conference of maternal and newborn health. And so we will bring people again and talk again how we are committed to changing the issues of maternity and newborn health. And last week, we were in a conference for cancer, and we spoke how we are committed about changing the cancer scourge in this country. and making patients have the best experiences and the best outcomes. And then in May, we are going to have what we call May Measurement Month, where we will be talking how hypertension is the silent killer. And there are many people getting strokes that can be prevented, children becoming orphans, increasing our burden of disability in the country, because when people get strokes, maybe they are paralyzed, they register as persons with disability, and then they are all vulnerable. And then we have to finance them through SHA, and then we have to make sure that they do not pay tax. We will all be doing that. And then mental health will come, and we will count each other and say that every fourth person has a mental health problem. Same country, same people, different meetings, different communications. We can't continue like that. At least I will not continue like that. And so, it's broader than all of us. I have to do something. And we have to do it big. And we have to be scared while we are doing it. But we have to do it anyway. And you know, because I've gone to jail before, I don't want to mislead you. But at least I'll walk that path. We have to do something. We can't keep talking and talking and talking and talking and talking. So what's the action? For me, it's our commitment to the health policy platform. How we put it all together. How we put it all together. To make us see who is putting in money, where is that money acting, and what is that money producing. And how are we measuring that? And how are we linking all of these things through one healthcare system, unified, strong, sustainable for all of us. And we must also know that there are two things in the world that are changing faster than we can accommodate the pace. One is technology, and two is healthcare itself. Many of us who are in the healthcare professions know the old saying that if you read a book, you're 5 years behind. If you read an article, you're 2 years behind. Something is happening now that has not been recorded, has not been measured, but may be the future. That's healthcare. And technology is the same. Whether it's technologies for rapid testing, technologies in the software space, we are now dealing with a lot of issues around AI. There's a lot that's going on. So as we discuss old things 10 years back, this integration conference should have happened 10 years ago. Am I right? But they say that the next best time to plant a tree is now. So let's go plant the tree, not talk about what kind of tree. Let's plant the tree today. Because technology and healthcare are changing, and they are fast-paced in the change. And we must change too. But putting this platform together, which is the integrator, gives us a framework that allows us to absorb the shocks, allows us to absorb the panic but also allows us to push forward in a more focused, in a way that we can control somewhat the outcomes. Because sometimes change can be unseen, sometimes change is very seen. But what you can't deny is the result of change. It will either give you a crisis or a transformation. So when we live here, we have to choose whether we will apply some level of discipline that gives us a crisis later or a transformation. And I think that is all I have for you. I know you have the knowledge. I know the tools are there. I know each one of you are powered enough in your mandates to take this action. And for me, is to infuse this level of urgency to have an integrator. The integrator. Because if we don't talk about the integrator, all these integration ideas will fall by the wayside. Then we will piece them together, endorse some beautiful declarations, and then go back to Nairobi. And then I'll see some of your faces in next week's conference of maternity. And you will not be talking about HIV response. You will now be talking about maternal mortality. And I will not continue with you like that. Thank you so much, and best wishes.
Why are some people standing, others seated? Can we all of us stand and give our peers a better round of applause? Please, thank you, thank you, thank you, thank you, thank you, thank you so much, our peers. You may be seated. Those of us who have a privilege of listening to him every day, he's a disruptive thinker, and we enjoy his remarks. Thank you so much once again. Dr. Gondi, we recognize you and those who came before. I have been asked to bring the MC who will proceed from here, the panel, but most importantly, once again, I am sure our PS is engaged in another assignment. So we shall release him to go, but keep thinking of what he has spoken to us about the change that we need to be. Thank you once again, Bwana PS. Thank you. Bwana MC, come and proceed with the next program. Thank you so much. Thank you.
Only one question is what has been allowed. Yes, only one, please. We are doing very poorly for time. Give him.
Let the PS finish the call. No, the PS will not hear. Yeah. No, he won't be able to hear.
Somebody will, you can just go ahead, please, because of time. Somebody will be able to repeat the question. Just go ahead, please.
No, he says I wait. No, he says I wait. Yeah, but you see, it is so personal. No. So what do you want?
You will veto. We have let them. Let the two of them ask. Two. Give them.
Kilonzo. Let's allow MC do his work. When MC, the PS is back on stage. But,
Yeah, sorry. Where's Kilonzo? Yeah, Kilonzo. You must be very popular. You carried a lot of people into the room.
Okay, thank you so much, Bwana PS. You know, we have worked together and I know ni mtu wa kusema na kutenda, eh?
Asante.
But one, community unataka power. When it comes to integration, we are the people and we are the people. So, we are supposed to be in the center of the conversation of integration. And we don't want where the government becomes the integrator, whereby we are forced on the throat. And on your talk, as much as you are so truthful, there are some words you have said, like by force, and that's where we are to have that conversation. Because we are the service users, we are the recipient of these services, of which are very critical to us. And when we go back, we're leaving this Mombasa with some questions not answered, as you have said, the integration is not going to work. It's all of us to work together as a team so that we have a comprehensive, because you know the dollar has gone and it is gone. But it's us Kenyans and our constitution of Kenya, whereby we have the rights and it's stated, and for the government to give us the dignified rights in terms of health. And that is where we stand.
Good.
So I have also a question.
Yeah.
You have talked about many things, and many things are neglected as you go to integration. For example, we talk about STIs, hepatitis. I don't see any budget to that. Dr. Bosire has talked about many things. But we talk of systemic. We have never seen such budgets in that. And also, Dr. Bosire, as I've asked the PS, on your side, we want to see, you have talked about men. We want to see how we are going to use gender transformation approaches to engage men and boys in terms of this integration, how they can success. Because when you leave men with these, things will not work. So we need to have a comprehensive package. Thank you so much.
Thank you. Thank you. Thank you. I think you are at the center of the conversation already. And but where is the other conversation? The conversation, Mulu, are you people doing a conversation outside this room? Because all of you are here, right? Ngojeni kidogo. You know now you are drawing me to my territory. I am best at what you are doing. Eh? That's why I've come back. I am very good at it. So you're already at the center. I want us to agree. Are you at the center of the conversation? Okay. So what do you consider being at the center of the conversation? So no, wait. So how do you want us to speak about the human rights and gender conversation?
We are right holders.
Yes.
My wakil is here. So now,
just help me.
Start by addressing.
Yes, my dear. Just allow me so that you guide us. How do you want that conversation to go? Now you hold the mic.
Okay.
So proceed.
Okay. Sawa. So, we as communities, we are having issues when we are when we want to access our services at the public facilities.
Okay.
Right now, we do not have a problem of integration. It is the stigma. It is the discrimination. It is, so how do you guys want us to address those issues?
Okay.
We need to come together and have our issues articulated in a space where you guys are going to design programs, co-create programs with us without excluding us. You guys are erasing the community structures, which was a safe space for us.
Thank you.
So if you are erasing our structures, it means that the structural barriers are not going to be addressed.
Sorry, who is erasing the structures? I want to deal with it right now. I hold the pen, my dear. I want to sack somebody, so just tell me who is that.
No, if you sack somebody, I'll also be sacked.
No, I want to sack the person who is erasing the structure because I'm the authorized officer. So tell me.
Mr. PS, we have no problem with integration. It's their model of integration. They are forcing us to go into public facilities.
Who is they? Who is they? Who is they? Who is they?
We are having the counties.
Who is they?
We are having the national government. And you know the people who are in charge.
No. Is it me? Who is they? I have to deal with that person today.
So, Mr. PS, as long as we are able to integrate the services into our existing diocese, that is what we as communities feel that it is integration. Bring the service providers to our diocese. Give us the malaria commodities. Give us the TB commodities. Give us your service providers. We are going to work on other things, but do not erase our spaces.
Thank you. So whoever is erasing the space, please do not erase that space. At least I am not the one erasing that space. And I wanted to live here with a very clear identity of that person so that we deal with that person once and for all. And I am with you, okay? Kilonzi, I am with you. Nitakuja unitengenezee term ingine, sawa? So umejua ile term ingine, mimi hata sijapata full term, so utanitengenezea hiyo term ingine. Yes, Kamau. Kamau, wewe Kamau, we spoke so long. I thought we finished all our issues. You see, even the mic has refused to help you. And please, I beg that I also leave because MPs are waiting for me. And now you see all these things that you're talking about here, integration. I need a budget for them. And without the MPs having me now, they'll not know that I'm also dealing with a very important constituency. They'll think they are the most important constituency. You remember the 8-year-old I talked about? When the physician is seeing her in the HIV clinic and the pediatrician is waiting, the other person doesn't think that this other one is doing an important job. But we need to have the full visibility, the integrator. Yes, Kamau. Just come here. You are my friend from long time ago, so just come and speak from here.
Thank you very much, Dr. It is true, and I like that you're going to meet the MPs for the budget, to ask them for the budget. So my question is, have you costed the health integration and to see how it is going to go, or are you going to start a pilot of several counties and everything to see how it works, so that any teething problem can be done? Remember, we are the first in Africa on this. even countries like South Africa and others have not done. So it is going to have a lot of teething problems. And so if you've costed it, that is fine. But you should have involved some civil society members. That's number one. Number two, within the integration, we have civil society members here who can be on your committee to be able to help in seeing what the problems are and how to solve them. Thank you.
Very precise. I think Kamau has been hired by me to help me because Kamau and team, where's Otuoma? Nelson and good. So I think we all sat with the team. I even mentioned to you the figures, what it would cost us. And yes, we have costed. We have very clear evidence of what it means to integrate and how much we need to do so. But we don't have that money. Yeah? So knowing what it costs, that we do. And I think I shared it with you, the team in the boardroom, how much it means to integrate. When we're looking at all of these services, almost 153 billion Kenya shillings. That's way more than the budget of this State Department. And so we have to make tough choices. And that is why, for me, I am extremely comfortable with uncomfortable conversations. Extremely comfortable. Extremely comfortable with uncomfortable conversations. The bigger the challenge, the better. And I will be there. Because we have to do something. So we know all of this, and what I hear and what I agree with is that all of us want to be in the room, to participate genuinely, and to feel involved. That's what I hear. And that's what I want all our teams to come out with. Zero exclusion. That we all move forward together and that we all confront those difficult decisions together. But I also know that we will triumph. As you can see, I have zero panic in my voice. I'm very clear that no one will miss the services that they need, not at the community level and not at the facility level. No one. And that we have demonstrated over the last 15 months, since the stop work order, since some of these transitions. I want anyone to come out and say, I missed my services. Even as we are doing this conference, 10 years late, maybe 15 months into the emergency, we have assured the Kenyan, every single Kenyan, of services. And we have provided it. And I'm not speaking about it as rhetoric, it's true. And I want us to calm down. I want us to throw anxiety out of this room. I want us to come back here with open hearts, clean hands, and do the work, and build the integrator, and build the future. What we are talking about is not just about tomorrow when we leave here. People are going to get their medicines, they're going to get their services. But we want to build a system that works, that removes the stigma, that removes this exclusion. And that's the work that we all have. And that's the work that I mentioned we have across all the other problem areas: maternity, mental health, NCDs, hypertension, all of these things. We go to places. Do you know that more than 43% of all our deaths are still due to cardiovascular disease. There are many people, and they keep asking, at least for me, they ask us all these questions. So what are you doing about rheumatic heart disease? So the integration is not just about the HIV services. It's about the entire healthcare system. It's about making it work. The financing, the health workforce, the digitization, all these systems. I had just within the HIV response, we have 28 different systems. And we are talking about digitization. I don't want to give another speech, but I want to thank you and I want to wish you all the best. Let's work.
Thank you very much, PS, for those not just thought-provoking, but action-provoking words. Let's give him another round of applause. Asanteni sana. So I promised you that the session was going to be heated, and that is just a precursor to that. Now, I also mentioned that Dr. Bosire has quite a long list of accolades, and part of those is that he has played a role as a member of CAC for Nyamira County, running health. And please allow us, distinguished delegates, that we move on with the conversation. And I wanted to invite to the podium our second speaker, who needs very little introduction, Dr. Richard Amanya. Dr. Richard Amanya is the country director for UNSAID for Rwanda, Kenya, and South Sudan, based in Nairobi, and he has extensive experience working with UNAIDS and working in these particular fields across Africa and the Caribbean region. Daktari, karibu sana.
Thank you. Thank you. Thank you very much. Good morning, everyone. I like the conversation in the house. Integration, if it is too peaceful, it shows we are doing business as usual. And so from what I have heard, we shouldn't go on the path of crisis. We should go onto the path of transformation. How do we harness all the different ideas and minds in this room and make sure that we have a pathway that works for everybody as far as integration is concerned? And as the PS said, we are being forced by circumstances to do integration. And it is very clear that the money is not there. And if the money is not there, our theory of change should be that with the little that we have, how can we maximize the output of what we have? And so my discussion with you this morning is about how do we do integration for adolescent and young people beyond HIV. Basically, that is what my task is. And I will start from what the PS did say. He said some 13 years ago, he saw an 8-year-old. Let me just assume that 8-year-old is 10 years old, and so fits into the adolescent age. And aside of the clinical care that was being given to that child, and for that matter, the adolescent, as I've upgraded her, there were lots of social issues. So the structural determinants, what that child and the grandmother are thinking about, is beyond healthcare. So I want you to see this conversation within the frame of health beyond what we see it. Health is beyond the health sector. Health also includes other sectors to make all of us very strong. So beyond HIV means that we need to look at all the different social determinants of health and how it impacts on the individual. I'm waiting for my slide. It is not yet here, and so I'm still waiting. Yes, and it is important that we think about it that way, that health is not just delivered within the health sector. Health is delivered by other sectors too. Agriculture has a role in health, and so do institutions of peace also have a role in health. So for that young person, it is important for us to look at ways of addressing their needs. So for adolescents and young people, when it comes to the dynamics of HIV, we know that every week we have over 3,000 of our adolescent and young people acquiring HIV. And that is why it is important for us to talk about this. And we know that in 2024, 16 out of every 100 new infections was contributed by an adolescent and young person. So they are important in terms of the conversation of integration that we need to talk about. It is also because some of the vulnerabilities that they have, most of it being structural, are not just the biological predisposition that adolescent girls and young women have, but it's also the whole issue around the economy, issues that relate to their gender. All those things are important because if you have a household that is poor, you put yourself also at risk in doing other things that naturally you would not want to do. And we think all these dynamics impact on the vulnerability of our young people. So mental health issues are key. And as the PS said, we all have mental health issues. How is this impacting on our young people? We know the potential of our Gen Zs in Kenya, not here alone, everywhere. So without they being on the table, it is a difficult conversation that you would have. So no matter what policies you have in terms of integration and all that, when they are not part of the discussion, and I can see clearly that communities want to be part of the discussion in deciding on where they receive their services. And I think the questions that came was really a very important one. In Kenya, it is very important. Over 60% of the population is below 24 years old. So if you have that land chart of people who are impacted, then definitely you need to be able to factor their voices in every development work that you want to do. And we also know that up to 75% of the population is below 35 years. This is the active group of the population. They are the innovative ones going into entrepreneurship. They are in school. They want to do something, and a whole lot of things that these young people with their young minds are into. And so how do we tap into this demographic dividend that Kenya has? It's huge. So how do we ensure that health does not become a barrier for these young people? Definitely, the next policy maker who will be standing here like Dr. Oluga is going to be a young person who is following a certain path in the career to be able to inform what happens within the health sector. Maybe at the end of the day, they would actually define what integration really means based on lived experiences. And it is important for us to keep that in mind. We cannot have our health security if we don't have adolescent and young people, especially when I say less than 75% of them are below 35, up to 75% are below 35 years, and about 60% below 24 years. Anytime there is a pandemic on our hands, these are the populations we need to be able to engage. So it's also part of our health security, and we need to be able to invest in them, because once we invest in young people, not just those having HIV, but think beyond that, then we are investing in their health, making them strong, building very robust human capital to champion the next phase of Kenya's development. So it is very important that young people remain at the center of this response. Many of you may have been part of the development of the Global Age Strategy, 2026 to 2031. In this strategy, it's very clear the shift has begun. It's no more siloed programming. It is about integration. Integration, integration, integration. And so if we say communities are going to be at the center of this integration, definitely their voices matter on the table. And as I always say, if you are not on the table, then you are on the menu. You will be eaten up. But when you are on the table, you decide what happens. And it is important that we have communities in this platform shaping how our integration should look like. And in this strategy, it's very clear that it is not focusing just on HIV, but it's looking at all other needs. The theme of this conference is about removal of barriers, and most importantly, providing holistic care. So holistic care doesn't just mean that I have my HIV services, but there should be some other wraparound services that addresses my vulnerability, that addresses my risks that I have. How is our health system crafted to be able to respond to these needs? And so it is key that we have young people, the community of young people, at the center of this conversation. And the spaces, and you could see the question that came, don't disrupt our spaces, the safe spaces that we have, that we receive our services, don't disrupt those. And I think that is where the difference is in this conversation. The health system is thinking this way, and the community is saying, you can deliver health, but you don't have to force me to come into your way of thinking as far as health is concerned. You can deliver health in other spaces as well. And that is why the way we think about healthcare delivery needs to change. So if the one who is utilizing the services is giving us feedback, how are we, the policy people, reflecting on that? You know, at times you need to build a certain framework that makes life easy. It's easy to manage, it's easy to monitor and all that. But I tell you, if you really want to meet the holistic needs of everyone, then you need to meet them in the spaces that they are. So this is a policy challenge that we need to see. That if we are having CHPs, if we are having other healthcare cadre, how are we leveraging those to support other people who may not feel comfortable? If you cannot fly, use a train, SDR, or you use a car. You know, so we need to think innovatively as to how we can get to a destination. But it shouldn't be one size fits all. One size fits all means we are doing business as usual. So it doesn't fit into our theory of change that we want to see. And so in that space that I'm talking about for young people, it needs to be youth-friendly. And we have tried most of these models over the past 20 years or more. We've tried a lot of models that have worked. Let us not jettison most of those models just because we say it is now government-owned, government-led. It is also about the people. The model has to change. The model has to be adaptive. The model needs to fit into the lives of the beneficiary. And so we need to have a mechanism in place where we can get feedback from the users. If we don't have a very strong feedback loop, we will not be able to modify our services to deliver quality care. Delivering quality care means a lot. How am I receiving my services? Some people may not want to show up at the clinic. And so, if we are now in the digital world, what prevents us from having a clinic on the phone? We can do that. So, in triaging, especially if the person is really not sick but needs a certain level of care differently, you can do the screening on your phone. And then you say, okay, where we've gotten to, you need to move to this other place for a service. So simplicity, efficiency of delivery depends on us being very innovative. So for me, it is very important, this conversation about communities is to let us dig deep into our pockets and think, what else do we need to do to be able to meet the needs of everybody? So for the strategy, we've centered on communities. So it is a big part. Communities are the center of the global AIDS response. And we want to move from the siloed HIV thinking into an integrated health delivery system. Because we believe that if it is integrated, what happens is that you will give a more holistic care, a care that goes beyond swallowing of pills, a care that looks at social protection and inclusion of people, your mental health issues, issues around sexual reproductive health, STIs, all other things are packages that you can have if you have communities trying to locate services and contributing to what other services they need and who delivers those. They are not experts. Communities are not experts. So the experts need to come and deliver these services to us. And I think that is what the communities are demanding for. And we need to be able to do that. And for adolescent and young people, the game changes. I'm proud that Kenya has launched the Lenacapavir as a prevention tool. And they made it available to everyone who needs it, including adolescent and young people. That is where it starts. It is frightening to hear that girls are 2 times more likely to acquire HIV than boys, based on the data that is there. That is something that we need to take a look at. And also, we know that once you prioritize some of these services, that makes it less cumbersome for them to be coming for the health sector. You don't have to show up every 2 months. You don't have to show up every 6 months. Once you have one shot, you are good to go. Your next move is the next 6 months. And it is important that we center. And so the Global AIDS strategy is centering long-acting antiretrovirals as a prevention intervention. And we are saying a minimum of 20 million people should have Lenacapavir, for instance, minimum, so that we can be able to benefit from that innovation. And the strategy is also centering on the fact that we need to have the services being delivered as a one-stop shop kind of. And so when a young person comes to you, that young person is not coming to you with hypertension. It's not coming to you at times with diabetes, which is more of somebody who is above 50 and all that. And so for a young person, they want the services to be tailored to their needs. And that is why when you have a person-centered services that you deliver as part of this integration journey, then you are meeting them with the services that they need. So it's about sexual reproductive health, especially when there are issues around teenage pregnancies and all that. How do we provide family planning services for them? And so this kind of wraparound services is key, including mental health. And on the first day, there was a discussion about morality. Let us not bring morality into this conversation, because comprehensive sexuality education is an important empowerment tool for our young people. let them know for them to take action. And I think that is also something that is being highlighted. And so what the young people are saying is you need to ensure that we have equity and inclusion. Also, there is this issue about the triple threat, which I would want to touch on, which is very important. It's not just here in Kenya. It's a conversation that is going on our continent, and it's all about how we deliver integrated services and how education also plays a role. So when I say health is beyond just the health sector, it's also about the education center. And you know, when a girl becomes pregnant, a teenage girl in school becomes pregnant, the policy is you don't go back to school. You have to stay at home. And so we need to be able to now see how do we bring these girls back to school, because education is a game changer for development. And it's also about social protection and then how we get that through. One of the key things that I would want to mention is about the issue about digital integration. And we've been talking about the DHA here. It plays a role in the sense that if I need to have telemedicine for my care, obviously, I can still be in school and during break time, consult with my provider and then know what to do. And I think we need to think about simplification. That can also help us. So moving forward, I'm thinking that as far as getting the voices to be inclusive in terms of how we shape our integration, we definitely need young people to be part of the design. The governance arrangement is important. Young people should not just be participants, but they are leaders, and it is key for them to be part of the policy conversation, like here. And if there are technical working groups, young people should be part of that technical working group in shaping up whatever services that are meant for them. And in terms of monitoring and accountability, we've had experiences with issues around CLM. And so young people need to be part of the conversation as far as giving you feedback in terms of the services that they are receiving. And financing the PSAs, there is no money. There is no money, but it is important that we find the money. But then, with the little resources that we have, how can we efficiently use that resource? Because at times, it's when you bring the services together in a way that people can utilize it, you can actually gain efficiencies through that. And so gaining efficiencies is key. And I know Dr. Muwa is interested in the whole issue around social contracting for young people and all that. That is also something that we need to consider as far as this is concerned. I think this is my last slide, which is saying that we need policy people to do their job. We need the donors to also do their job, and we need civil society to do their job, and we need communities to do their job. And I want you to focus on funding siloed programs, because if you stop funding siloed programs, we are forced into integration. So that is something that we need to do. We need the resources, but the resources should think about strengthening the system. And that is one of the things that we definitely need to do. But we need our policymakers to make sure that resources are made available for our people to use. And for civil society, it's about how do we engage to address issues around stigma and discrimination, and also making sure that communities of young people are actually at the center of the response. Thank you very much for paying attention to me.
Thank you very much, Dr. Please, let's give him another warm of applause. As he sits down and he's talking from experience, I also wanted to mention that part of the very many achievements and the belt of Dr. Richard is that he played a very key role towards the decriminalization of HIV in his terms of service in the Caribbean. So, ladies and gentlemen, finally, we call in the OG, the director for the Network of Empowerment for People Living with HIV, a man who is known to very many for the service that he has accorded us, Nelson Juma Atuoma. He will be putting the last nail on the casket around putting communities front right and center. Ladies and gentlemen, let's give him a round of applause as he comes in. Nelson.
Good morning. Yeah, we are following on the protocol that has been there. And I'm seeing if we are not careful, we are going to talk to seats. The few of you who are here will be listening, but the seats will not be listening. I think I'm supposed to talk about something that has been talked about. Everybody has been talking about communities at the center. So because we are running between tea and also between breakout sessions for the community villages, I will simply do one slide here because it is repeat, but later on I'm able to respond to a few questions. But thank you very much those who have been here. And I think the morning was really very eye-opening. And I can also tell you outside this presentation that there are people in this country and there are people in this sector, health sector, starting with the PS, going to the CS, and they have a boss in the name of the president. If any day there's any war between you and them, you will only win that war if you avoid the war. So with the PS Oluga, avoid the war, you win the war. If you get into war, you will always win. So we are talking about integrated people-centered health services. And the call we are talking about is to have communities at the center, the communities in their diversity. But that community must have capacity. That community must be empowered. So in this slide, I'm talking about the communities need to be capacitated, empowered, and resourced so that they also understand and play their role, take up a responsibility. And I think from HIV, and you've listened to the regional director from UNAIDS, and earlier you listened to CEO of the NSDCC, we have lessons that where you have communities, where you have people living with HIV, the result has always been optimal because they leverage on their experience. And that's why from day one, I emphasize self-care, but it does not end with self-care. It goes also to do with the body care. So all this, this is the slide I wanted to talk about. When we met here 2024 Service Delivery Integration Summit, we on ourselves also took it upon ourselves to go and find out to what extent, what are we looking for to make integration work? And because from Sunday, from Monday, what we have been saying, the question was not going to be if, the question was going to be when. But yesterday we were also told that it is not even when, because it is happening, it is how to make integration work. So the UNAIDS supported us to undertake some consultations, and we relied on GNP Plus, because already during their leadership summit early last year, they also had a minimum standards. So this slide has what we put and what we will be putting forward to the Ministry of Health and NASCOP to also find its way on how best to make integration work. Community engagement, which need to be coordinated, structured, and meaningful. And of course, we need to talk about where resources will come from. And in this country, there's a commitment for social contracting. And that's why I was telling the CS that, yes, we agree with the Ministry of Health leadership, but the NGOs, the FBOs, the communities must also play a role. And for them to play that role, where are they going to get the money? And of course, we emphasize the issue of gender and human rights framework that is anchored on our country's laws, policies, and guidelines. And then we also want a system that has inbuilt mechanism for giving feedback. When we talk about community-led monitoring, we are simply talking about recipient of care being able to give feedback on quality and access of services so that we move together. And when we bring questions, it is not that we are antagonizing or refusing. It's simply that we want clarity, and then we know how to move forward together. And of course, from day one, I've been emphasizing this is the time to scale up differentiated service delivery. And by differentiated service delivery, we mean that we want to invest on recipients of care so that they also become responsible for certain things through self-care and also self-reliance. And that is how we are going to together end HIV. So all this you are going to see in a booklet that NASCOP will be preparing the report. So you don't need to worry that about me running slide by slide and every sentence. But what is important is that we also try to create time for different group dialogues. But there's one challenge also I want to bring to our attention. We may talk about community engagement and so on and so forth, but where is the money for communities to engage? And where is the interest? And where is the motivation? In some of our counties and facilities, we are still struggling with what do we mean communities? And we have examples from Murang'a County, Nyeri County. The question is, can we still have recipients of care joining as CHPs? And how can we leverage on the lived experience competitively so that you don't earmark people for positions to help the Ministry of Health? So with that, I wanted to invite my colleague, because I'm also part of this next session. So, okay, let me get it back to the MC, then we can move forward. I'm used to being clapped for after I make a presentation.
Thank you very much, Nelson, for that. When Nelson speaks, he is a community. He carries the voices of a lot of the community people. So please, let's give him one last round of applause. I know we're doing very poorly for time, but to summarize what we have heard from this very formidable panel is that we need the policy architecture that Dr. Douglas builds. We need the long-term vision for young people that Dr. Richard is championing for. And we also need an apologetic community voice that Nelson embodies. And if we heed these three calls, then this shifting financial context will not stand a chance. So ladies and gentlemen, thank you very much for giving us your attention. I know we have another session right after this. I don't know where Chairman has stepped out to. Dr.
Yeah, I'm done. All right. Thank you so much. Let's clap for Dr. Balu. I think he has done an amazing job. In between. Yeah. Yeah, so we are trying to manage time, and I know that the morning session has been very loaded, but we hope that we'll be able to catch up time so that we can allow for the community village discussions, which we expect to be very engaging, to continue. So I don't know, just checking from the crowd whether there's any burning question for Balu and the team that has just done a number of presentations. Any burning question, input, comment? All right, I don't see any. So let's clap for them again. To begin my coffee. Is that okay, so we can allow maybe just for one. Okay, two. Nimemalizia hapo mbili peke yake. So who can take the mic?
Thank you so much. The first presentation by Dr. Omanya, talking about AYP. And we people from disabilities, we felt left out somewhere, because I know this working will go back to the boardroom to be analyzed, and a guideline will come up. But if specifically we are not talking about PWDs anywhere, because PWDs, we have very unique problems. And PWDs as a community, which has various categories, need to be considered and needs to be spelled very clearly in the integration process that is coming, so that you have a model that really will capture all of them. And I want to say that disability does not knock your door to tell you that I'm coming. So even today, as we go to more discussing about disabilities, let us all know that we are candidates. We can be there tomorrow. And therefore, it is something to be taken with all seriousness possible. Thank you so much.
Let's keep our questions short, please.
Thank you so much. And I'm excited that we're shifting the conversation, shifting from talking technicalities to talking people, to talking barriers, the theme of the conference. For sure, from what we've heard this morning, we are very good at naming the barriers. We've named them, we've identified them, we've acknowledged that they exist. But the true reality is that we've not had a discussion about who is responsible to fix these barriers. How are these barriers going to be fixed? We need those barriers fixed now. How is that going to work with the discussions about challenges in financing and challenges in and so on and so forth? So I think as we move forward throughout this day, I'm looking forward to beginning to shape some real commitments around how we are going to address barriers, so that we are not just talking about integrating services, but we're beginning to define some resolutions around what needs to change and who needs to make that change.
Yeah. Hello. For me, it is, I have basically been listening, especially from the PS, and I really thought that the way he approached the whole integration issue, it was a bit insensitive, because this is a very, very sensitive topic. And we would really love that the government and all the stakeholders involved approach this particular, be careful about the language. It's not a done deal. I think it is basically a living reality, which we'll continue working on it as we go by. And of course, it's important we listen to all stakeholders. There's the corporate sector here, there is the community here, and there's the government here. So all of us are basically a very, very important contributors to this. Thank you.
Thank you very much. So very quickly, on the issue of inclusion and disability, we hear that very loudly and clearly. So that will form part of this. And on the issue around the actual barriers, commitments, and who and what needs to be done, session which touches on the last comment also around the sensitivities of parts of the human rights issues that, and as I can't speak as government, but I can speak as an auxiliary to the health authorities, that is quite a shared opinion. Now, as to concretize this discussion, the upcoming session, session 17, which will provide for the stories from the actual lived experience from the communities, then is hoped to be able to deliver on this, so that we can have very firm commitments around this. And I will ask Dr. Bosire to respond to any of the questions.
Thank you very much. You know what you are taught in government is that there is no vacuum. So after Menya has left, the PS has left, and some questions have been shot, maybe not at me directly, but there is no vacuum. We can respond to those questions and maybe put to rest some of the concerns. So one of the speakers has talked about inclusion, comprehensive, meaningful inclusion of people with disability. we do know for a fact that 15% of Kenyans have some difficulty in at least one domain or another, one functional domain or another, 15%. That's about 7.5 million Kenyans, 7.5 million Kenyans. And we are aware also that about 40% of people with disability have faced one form of barrier in accessing health services or another. So that is not lost to us. That is not lost to us. And as I answer the second question on who does what, this process must be government-led. The government must be leading, but with everybody on board. Because if we are going to talk about sustainability, if we are going to talk about protecting these gains, the government is the one which has the responsibility constitutionally of protecting the gains of these responses over the years. So, but as it does so, it cannot do it alone. It has to do it with the communities of beneficiaries of the services. It has to do it with the communities of the people infected or affected by these diseases. It has to do it with our partners. So the thing is, government must ensure that no one is left behind to the true clarion call of universal health coverage. Then the last one around from my brother Richard, maybe I would like to pick it up. If there was one or two sentiments from any of us that has made you a little bit uncomfortable, because we know this is a progressive process. We continue improving. Nobody is perfect. Maybe you could just see us after this so that we can see what to keep improving on. But overall, ladies and gentlemen, let's give it to the PS. He did a fantastic disruptive speech that is supposed to cause action in the deliberations that we talk about. He challenged us that he doesn't want us to talk about same thing every day, same thing next week, the other month, and the same faces. That it's time we got our boots on the ground and implemented, put our mouths, put our monies where our words are. Thank you very much.
All right, so that will wrap up that session. And do we have Diana from AHF here? All right, so kindly put on the presentation for it. So I'm going to guide on how we are moving to the next session. We have a very short presentation from AHF, who was one of the partners who has supported this summit. And after that, we are going to have Ludwig come in with another short panel on the lived experiences before now we proceed to the community villages. So kindly, Lord, all right, the presentation for Diana. Oh, this is the first presentation. It's the first slide. Yeah, that's the next. Okay. So tukaribishe Diana, tumpigie makofi tafadhali from AHF.
Okay, good morning, ladies and gentlemen. It's my pleasure to speak to you about a community aspect that the AIDS Healthcare Foundation is implementing. Like I was introduced, my name is Diana Tibesigwa. I work with the AIDS Healthcare Foundation as the Regional Police and Advocacy Manager for East and West Africa. And I'm based out of Kampala, and we are two participants from Kampala, but we support the region, in addition to our colleagues who work here in Kenya. Just a little about the AIDS Healthcare Foundation. For those who don't know about the organization, AHF is the largest HIV nonprofit organization, currently in 50 countries. In Africa, we are in 15, providing HIV care and treatment, prevention, and also doing advocacy to ensure that we provide an enabling environment where HIV services and other public health issues are responded to. Currently, as part of our efforts, we are serving over 2.8 million patients, and of the 2.8 million patients, we have 1.4 million patients taken care of in Africa. So we have experience working with the community. When we talk about patients, we are still talking about the community, the people we serve. Majority of them are settled within the communities where our services are. And these are some of the service pillars that we offer as an organization. Grassroots mobilization for improved service delivery, as AHF recognizes the power of grassroots advocacy in mobilizing communities to address social problems and advocate for policy change. And we've heard from the previous speakers and some of the voices that were coming through. The attacks that we see here, I think, presents to us the gap for providing communities a platform to raise and participate in processes, participate in new programming, and the model that I am presenting now provides a structured community platform to get involved into implementation of different government initiatives. They could be health, they could be education, but also get involved in the decisions that government and other stakeholders may want to take on, but ensuring that the voice of the community or the vulnerable person is fully involved in the decisions that are going to be made. Then we, as an organization, we thought it important that for us to be able to improve services, to ensure that we have the client, come to the clinic, to ensure that the other services that a client may need that we are not providing, we thought that grouping them in communities beyond even the HIV client will serve in responding to health-related issues that go beyond HIV. And this is what the Community Power Voices model presents to us, and we have seen a number of achievements coming through it. In Africa, it is implemented in 14 countries. So what I am sharing is some of the results or outcomes that are coming from the 14 countries of implementation, engaging communities beyond the patients to be involved in the decisions that they are making around healthcare service delivery. We have spoken about integration, and we agree that it is not a single structure that can achieve it. All of the other elements have been spoken about: policy and regulatory frameworks, health workforce, health information system, the supply chain, commodity management, the financing, the resources. And I think what we need to get clear is how to get the communities involved. But for this specific structure, we're looking at an organized community that brings together the leader, the patient, the young person, and mobilizing them, preparing them, training them, educating them to be able to participate in the government processes. And these processes may not necessarily be health, because we know as we discuss health, we also have other determinants of health that are outside health. And so this community brings in all those aspects and respond to the different health-related issues that we want to talk about. So what do Community Power Voices bring on board in terms of integration? We talk about demand side and accountability. So as we talk about the other processes of policy, the health information systems, the CPVs create the demand side. It is an organized community that monitors whether integrated services are actually reaching them and escalate when they are not. So when you tell us here, when you tell the community that the services are integrated, they will that platform will confirm if these services are integrated. They will confirm if you're still providing the ART on time. They will confirm if the human resource capacity is good enough in the different facilities. They will confirm if the waiting time, is different from the different waiting time that they had before integration. So this platform provides accountability, and when we engage with them, it provides accountability and feedback so that we act upon the different gaps that are being identified during the implementation of the integration agenda. Then community-generated evidence. The CPVs gather real-time data on service gaps, because part of the model also involves monitoring service delivery. So it is a cycle of 4 months, and in one specific month, they are able to move around the different facilities within their communities. They don't work in isolation. They work with their leaders. They work with facility leaders. They move around to monitor and understand why some of these service gaps, exist. And we know that some of the gaps, as much as they're going to be responded to by the facility or the leadership, there are also aspects where the community is responsible for some of the challenges that the facility is facing. So when they identify that dead data, it is timely because it is implemented through a tool called the Community Scorecard, which provides immediate feedback, data and immediate feedback, and also commits both parties to commit to changing some of the gaps that have been identified. So it generates data and it feeds into the decision-making processes. And it is primary data because they are picking it from the facility, they're picking it also from the people who have access to that facility. So when we engage with it, it helps us to inform the processes from bottom to up and takes away this aspect of top to bottom. So when we plan from the bottom, we're actually dealing with the real issues that are being affected by the populace. When it comes to bridging the HIV stigma in the integrated setting, we, across all our countries where integration, is being implemented, especially after this shift in financing, when they decided to change, how services are being organized within the facilities, coronary care, OPD, most of our clients that we serve in the different facilities moved away. And we have worked with the community power voices to speak to our clients. And slowly by slowly, we've been able to see our clients back. So the structure provides like a peer conversation, with the clients, educating them and making them appreciate and understand the change in service delivery. And slowly by slowly, it's been helping us to change the mindsets of the client. I think yesterday someone was talking about leadership, the leadership and the role of leadership in changing mindset about integration. Every one of us, when they introduced integration, it sounded like it is an animal, something that is going to affect us negatively. But I think slowly by slowly, we are getting to appreciate and understand why the shift. And for us to legitimize that with the community power voices have been center in engaging communities, working with government officials to speak to them and make them understand why this arrangement is happening the way it is. However, it doesn't take away the fact that someone mentioned that integration is not an event, it's a process. So it also helps us to make our communities understand and move, not in a slowly manner with government, because that should not give us a leeway in slowing our action as government and other stakeholders in fastening the integration agenda and commitments that we have made. But at least we work with the communities to understand that this is a process, and they work with you to hold you accountable on the commitments that you have made around integration. Then citizen ownership of the integrated services. Someone already mentioned here that if you come here and tell us that you're going to do integration and we're not owning it as a community, integration will stay with you and it will not come down to the community. So as part of the model, communities, advocate for core design integrated services. So I believe that we still have opportunity to engage with the community, but we need them structured, because when we mention community, and we are not providing a structured service within the process, it's going to be hard. So for us to have like a citizen-owned, initiative, especially this one that we are speaking to, we need to make sure that we involve them, and this structure, if scaled up, it can provide us a platform to do that. The Community Power Voices operates on 4 principles, and one of them is information. Like, we educate communities on their rights within the integrated services, because at the moment, if you go to these service points, people don't even know about how to seek these services. So part of what the Community Power Voices do is to educate the public about these services. It is not limiting them to access the services. They still, within their right, have access to these services, but they do not understand this. And such platforms are helping us to escalate that information to the community. Then share government standards. We have, I think it was the first day when we launched a number of policy frameworks that we have that are guiding integration. And we don't, most of the time, we have these beautiful frameworks, but our service providers, our communities, they don't tend to understand these. So the Community Power Voices, part of the activities they do, working with the technical teams, is to break down these standards and make sure that they resonate with them. When they understand these standards, they are able to monitor and see if what is in those standards is what is being provided for the facility, and they are able to hold different service points accountable. Then also, in terms of closing the information gap, I think I have closed that out, is that it provides us an opportunity to give the information to the community that they may not even be aware of. But also in terms of the different health-related information, it could be about TB, it could be about, HIV. Currently, we have a lot of new technologies and information. We use that same platform to make sure that we provide it to the community. Then the voice, it provides the patient a seat at the table of the health system. Someone spoke about patient involvement. The model does not only look at the patient, but it looks at the HIV patient. It looks at all patients. It could be a young teenage person. It could be an HIV patient. It looks at them and it brings their voices on table. The other element it brings is specific HIV clients, in the integrated facilities, then prevents HIV-specific needs from becoming invisible, in primary care setting. And I think this is the conversation. This is the fear that we have, and we believe if we have such platforms in the communities, we will not lose it all. The concept also provides dialogue. You see a number of dialogues in the pictures happening. It provides dialogue where the community and the leaders interact to share the gaps, to understand the challenges, and they make commitments and make an action plan on how some of these challenges are going to be responded to. So such platforms provide accountability, monitoring, and I think for me it keeps sanity also in the community as we try to implement progressively some of these initiatives. Yeah. So this is the cycle. It has a systems mapping, it has community orientation, monitoring, dialogue, validation of the evidence generated, and then the face-to-face conversation that they always have with their leaders. Yeah, so in terms of integration structure, like the entire process of integration, which I talked about, policy, health systems, health workforce, and financing, I think the Community Power Voices have a role to play at each of the points in the process. And if we involved them using some of the things that you see on the screen, data, dialogues, and also using that information to inform planning, even financing itself. Someone talked about financing and resources, but I think we are talking about financing from the top, up approach, but you're not talking about financing from the things and priorities that the communities want. But this now structure provides us that aspect where we are talking about resources, policies that are community driven, and they're informed by the real challenges that the communities are facing. I think I'll go to the I think this is very important, especially in knowing how these community power voices, they are established. Like I said, there are formal groups within the communities, they're informal, and we identify them through the community leadership. They are selected by the community. They are diverse in nature. They involve adults, the young people, people living with disability. So we have a diverse group of people within the community that comes together, structured way of raising resources, engaging and monitoring, and engaging in decisions that are affecting their community. They speak on behalf of the others and do mobilization of other people in the community to respond, to understand the health-related needs of that community. So it's a structure that is community-led. It's supposed to be community-led. So where communities lead on each and everything that affects them in the community. We train them on a number of things, community engagement, policy engagement, but we also make them understand the different policy, legal frameworks, in their countries that establishes such structures, because in some countries they will say such structures, they cannot operate here because of how the participation and legal frameworks in that country, align. But where these informal structures are allowed, we've been able to establish, a number of them. Like here in Kenya, we have over 60 community power voices. Where we have here in Mombasa, we have a group of 20 people that does the same thing. If you see the pictures there, you can see how the members who are putting on t-shirts, engaging with the community. Some of them are giving information. Some of them are working with health workers to do HIV testing. Some of them are speaking to their leaders, introducing the concept. Some of them are holding dialogues. So they are leading conversations and leading, information dissemination, leading, evidence generation within their communities, presenting it, to the decision makers so that it informs the whole continuum of policy and decision making. So this is what it can do. It improved HIV service utilization, strong systems accountability, citizen-driven sustainability, and then it reduces stigma in the integrated setting, as I explained before. Yeah, these are some of the activities that we have done. Like I mentioned, here in Mombasa, the CPVs have participated in talking to people about the SHA, and those are some of the numbers, that we have reached just in about 1 or 2 months. And of course, there are some challenges that they face, but at least they are part of, the government initiatives that are being, promoted among the citizens. So they also come on board to promote and participate in government programs. So when we use them, we can reach more population with this information. In other countries, they are engaging in HIV testing, creating awareness about STIs. In other countries, they are even engaging up to the level of parliament. So it's a very good community structure that if scaled up, it may not be necessarily the community power voices, it can be another structure, but in this sense, what we are bringing on board is that we need to have a well-organized community diverse structure that helps, in engaging communities to give feedback, but also to participate in the decisions that are going to affect them as the population. So these are some of the strategic actions that we are making. We may need to embed structures like CPV with the district or county health integration plans. We can align the CPV quarterly cycles with the national HIV integrated reviews, and timelines to inform decision making. We can link the CPV scorecard reports to the DHIS2 and National Health Information System because they bring in information, like I mentioned, they support linkage, they do back-end care, they do a lot of monitoring, and they have a lot of data. So if we link them, we can be able to capture that data. Then advocate for government co-financing for community structures. as we're mentioning here that we don't have resources, I don't believe that. I think within the resources that we have, as part of community strengthening, we can find resources to have structured community groups that are going to contribute and support integration. Then we could also forge formal partnerships with the line ministries, counties, to have these as formal engagements within the respective counties or districts. Then document and share the integration of these groups as evidence for scale up. Maybe in our next conversation, we'll discuss how this evidence can support scale up of community involvement in planning, decision making, in any of the health initiatives provided by government. So thank you so much. That's what I really had to share from AHF. Thank you.
All right, so thank you. Let's clap for Diana again. So we will not have time for questions, but if you want to interact with her on the work that AHF is doing with the communities, I think you can be able to speak with her in the sidelines. So I want to hand over the next session to Doreen. Doreen, to usher in the community panel discussion on lived experiences. And after that, we shall proceed for the breakout sessions. So Doreen, let's clap for Doreen as she comes on the stage.
Thank you so much, Doc, for leading the first session of today. So we are entering into another session that is going to be led by Ludfin on community involvement on recipients of care from their lived experiences. So I'm going to hand over this session to Ludfin. Ludfin, please take over. Please clap for Ludfin as she comes now.
Good morning. Good morning again. Do you want to stand up and stretch a bit? Yeah, just stretch your body. It has been a long morning. Stretching doesn't mean we leave the room. We had hoped that the room would be full because you recall that integrator that the PS was talking about. We want to now talk about what communities define as the integrator. So we would really like for every stakeholder to be in the room. We can sit down now. Thank you. And thank you for staying. I don't know whether Dr. Mulwa is in the room and their team. Yeah? Dr. Nelly, where is Dr. Mulwa? And the team of people that are leading the integration conversation. I've seen Dr. Bosire, but I'm still just asking. Okay. My name is Ludfin Bunde. I work at UNAIDS here in Kenya as advisor, Equality and Rights for All. Thank you for staying, really. The morning has been long, but we have appreciated that you stay. And as you stay, we would really request that you be present, even as you stay. Be present in terms of how you hear, how you see us, because today this session is going to be talking about lived. But before I go to that, I would like to really appreciate Dr. Mulwa, the Ministry of Health, and its two agencies, NASCOP and NSDCC, represented by Dr. Bosire, and the entire organizing team for including this session of lived experiences. But I want to appreciate you as well, the policymakers, the technical teams, the UN development partners, civil society, and communities and faith communities in all your diversities for the work that you do to ensure that communities indeed shape the responses that we work in. But now, because it's a community day, today was purely supposed to be led by communities, spoken by communities, shaped by communities. Allow me, therefore, to acknowledge communities in all their diversities present in the room. Persons living with HIV, AYP, women living with HIV, TB champions, people with disability, the leadership of communities in the non-state actors under the Global Fund, Philip, I saw you, Peter Njane, Nelson, Dorothy, Rosemary, Maureen, Madenge, Anguva, Brendan, Marianne, Kamau, Benson, all of you, you represent communities at various spaces. I know we are also joined by those who represent communities at the global spaces. The GNP Plus is here, the global network of people living with HIV, REP is here, we appreciate you. Maureen Murenga, you are here, you represent communities at the global spaces, we appreciate you. So our focus today is making integration work for people grounded on human rights, dignity, privacy, and non-discrimination. We've talked about policies, we've talked about how systems should be placed, frameworks, guidelines should be developed. But the objective of today, this panel, is to surface the real world experience of the people that will be using these services or are using these services. So therefore, allow me to ask the panelists to come on board. We are joined by Patricia Acero, the Executive Director, Ringa Women Fighting AIDS, a treatment activist, a community advocate. Patricia is our voice in many spaces. Next is Cheryl Plimo, an adolescent and young person, HIV and sexual health rights activist. She's the Executive Director of IREP. Next, we'll have Solo, Key Populations National Coordinator. Solo is our voice in that space to ensure privacy is protected. We will then have Churchill Alumasa, Vulnerable Populations. Churchill is the Director of Discordant Couples of Kenya. He is the chair of the Vulnerable Populations Consortium of Kenya as well. Then next, we have a young mentor mother, Mombasa County, Matilda. Matilda is a young mentor mother providing information, very critical information, on issues of adherence to enhance viral suppression, particularly amongst adolescent girls and young women. And last but not least, we have a community health promoter as a member of our panelists, Violet Kibisu. Please clap for Violet, doing the last mile of what we do in the health space. So, colleagues, I said, today is about listening. This session is about listening because we are technical experts. We are donors. We are policymakers, but we make all this for the people. So today, we would like you to listen to the people, to hear keenly what are they saying, and what are the proposals that they are making to all of us and to all of you. Because health without barriers and care that reaches people where they are must be defined by lived experiences and measured in barriers removed, rights protected and promoted so that lives can be improved. Simply put, for these guys here, an integrated health provision is one that is informed by the recipients of care and that is informed by lived experiences. So for my panelists, I will ask you to keep your responses concise, focus on offering solutions, and let us try not to repeat what someone else have said, because your experiences are really rich, and our audience would really like to pick the solutions that you are suggesting. So we start from the point of care. For Patricia, from your experience, how does service integration or the lack of it affect people's ability to access care and their overall experience in the health system?
Thank you so much, Ludfin. As people living with HIV, the first thing that we are grounded on is our constitution, and those are the laws of Kenya. That Article 43 is quite clear about the right to accessing healthcare, including sexual reproductive health, and that we also have the Data Protection Act, that even as we go into integration, we want to feel safe, that issues around data are protected. That we also want to feel safe because we have the HIV and AIDS Prevention Act, that our human rights, the right issues that colleagues were bringing up here are taken care of. But one very specific thing we want to put through is that our life is not divided into HIV, TB, malaria. So our healthcare systems should not do that either. What I've heard from colleagues is about the issues around fragmentations that everybody has been talking about here. The multiple clinic appointments, the records that are not shared, the reputation in the tests that they do, the high cost of transport, the time they lose. Because when we walk to a facility, the only thing the facility or the in-charges see is the disease. They don't see what Dr. Oluga was saying, that we are breadwinners for our families, that we need to work to be able to put bread on the table. So the time that we lose in the queues, the lost income, you miss screening. They say they miss screening in the facilities. The stigma. Integration has, we were hoping that integration will not have stigma and discrimination, but the way things were done, there's stigma and discrimination within that. So on the same, we are also asking that we know that it's not about policy. Where the problem is the implementation at the facility level. We think that what can work for us is a one-stop service. Nelson did mention it, I'll just repeat it, that we want differentiated care, and we look forward to community-led models. For us, integration is not more services. It is redesigning care around the person. We are looking for quality as communities, and for us, there's what we think quality is. It means one person, one care plan. It means respect. It means confidentiality. It means convenience. It means affordability, and it means continuity of care and equity for women, for a key population, for young people, and for children. What we believe should change is we have to shift to the person-centered system to integrate screening and treatment. And for people who invest, we believe that there are areas that need to be invested in, and that is healthcare worker capacity. Unified data systems and community-led care. If funding remain disease-specific, then the system will remain fragmented. Communities living with the diseases are partners, not recipients. Nothing about us is vertical. Our care should not be either.
Thank you, Patricia. Your insight powerfully grounds us in the fundamental right to be treated with dignity and coordinated care that therefore leads us now to a young person. For young people, we know the issue of trust is fundamental. And Jerome, from the perspective of young people, how well are services truly integrated for those seeking care?
Thank you so much, Ludfin. Hi, everyone. I think I deserve a clap for being the second Gen Z to sit on this seat. So, munipe power, sindio? And I'll sit properly so that all of you can actually hear me. One of the most important things that Mr. Oluga has mentioned is that none of us wants integration, and that's something we must admit and recognize. And majorly because for us young people, familiarity is so important. Imagine you have been going to a clinic every single day for years. You know your clinician, you know where the system works, you know where the pharmacy is, and you wake up overnight and all that is not there anymore. And somehow, somewhere, you have to figure out how to navigate that system alone. Trust me, for many of our young people, integration has meant us disengaging from the said health system. Not that it is bad, but because we've not taken into account that people need to be guided to properly understand how to navigate a new system. So one, guidance, transition, support, we have not taken time to do that. And even as we sit in this room, and I've had so many conversations, there is an assumption that we will all fit into the system, we will accept it as it is, and we'll be able to access care. But for us as adolescents and young people, there are so many risks that this system, if not well done, poses. I'll start with the first thing, reality. A lot of times we say, vitu kwa ground ni different. And in Kenya, on paper, everything is perfect. Kwa ground, guys, it is bad, ni mbaya. We must really accept that. What does that mean? When we talk about ensuring that communities and young people are able to access responsive services, we must ensure that it is actualized at implementation level, that the healthcare provider is well trained. We do not mind the older clinicians, by the way. We welcome them, it's okay. We are fine with that. But they should be able to offer non-judgmental services. And a lot of times when you talk about these issues, we are told, young people, you're complaining, you're demanding too much, but that's not the case, guys. It feels so bad and so judgmental when someone asks you, why are you having sex? So what answer am I supposed to say, to be honest? And so healthcare workers have to be able to provide non-judgmental services to adolescents and young people. It doesn't matter what age you are, you have to be able to come to the level of young people. Number two is confidentiality, and Patricia has mentioned this, and confidentiality at service delivery level. When we are interacting with healthcare providers, I'm going to a healthcare facility just near my community. Maybe that nurse is my mom's friend. Maybe that nurse is someone I meet in church. To be honest, you are not sure if you can trust this individual with your health information or even your health questions. So confidentiality is paramount, and not just in saying, but healthcare workers must be able to prove and convince us that they can keep our health information confidential, especially now that there's integration and there's task shifting, there's interaction with different healthcare providers. I want to be sure that my healthcare provider will keep my information safe. The other thing I want to highlight is an adolescent-centered integrated system. What would that look like? Number one, we have to ensure that we pick up models that were there in the separate system that worked and see how they can be integrated in the integrated system. The first model was the peer support model. To be honest, sometimes you just need to see a fellow peer who will assure you, I know what you're going through, I've been there, and all your problems and fears goes away. So we have to make sure we integrate the peer support system for young people in the integrated system. Young people can actually be CHPs. So create those spaces for us. We are supported by the government, then it becomes a sustainable system. And whenever any young person goes to a facility, they have a fellow peer to support them in case the provider is not able to fully support them. The other aspect is DSD, and Patricia has mentioned. Community ART group, pharmacy ART drop-in centers. All these options have been helping us. I do not need to go and interact with a facility if I'm not sick. And people living with HIV are not sick. And people seeking prevention care are actually not sick. They just want products and services. So we need to use models like DSD to be able to minimize the amount of time we spend at facility and even the amount of time and people who come to the clinic. The other thing is to really ensure that we resource our health system. And our director from UNAIDS said something. We have to put our money where our mouth is. The system has always been stretched. Now we have added add-ons. We have to resource it for it to be responsive, especially for young people. We need youth-friendly corners, youth-friendly days, where we are able to sit with our peers and actually discuss issues. There are so many complex issues that we might not be able to discuss with older adults. Thank you, guys.
Thank you. Thank you for spotlighting that the next generation. For you, access is defined by respectful communication and freedom from stigma. And indeed, when confidentiality is fragile, no one feels it most than key populations. They feel it first. And therefore, a rights-based system, an integrated system that is right-based, must protect privacy by design. And therefore, for you, Solo, from the perspective of a key population, how do people experience the health system when they try to access integrated services? Over to you.
Thank you so much, Ludfin, for that. And I am Solo working with the key populations. Us as key populations, when you are accessing services, first of all, you have to ask yourself, where am I going to get the service? Will I be stigmatized? Will I even be welcome at the door? As key populations, we have our drop-in centers, which are KP-led, whereby I will go, I will see the receptionist, their person who I can relate to. So already they welcome me at the door, making me feel very comfortable. And I know at least over there I'll be safe. As you're thinking about integration, we should think about how will we create demand of such safety. Getting into let's say a health facility, whereby no one is not looking at you. You know, people are looking at you those ones of, you look different. If I'm a sex worker, let's say, I've just come from night shift. So I still have makeup on, but I still want to access services. Will I actually be well received, right? Even people who are giving me services, will they ask me, you've just come from the bar, you know, will you be able to actually, take the medication or something like that? So that type of service that is actually well tailored for key population is needed. Then looking at when we come to issues of confidentiality, my health records, yeah? How are our healthcare records actually treated? Is it that I'll just find them on top of the table or well locked up? Or will someone actually now come and actually say, oh, I saw your healthcare card or something, and my privacy is actually lost? As key populations will get that if, let's say, I am identifying as an openly gay man, and then I go for service, then I'm asked, oh, so how many condoms do you need? As if you're actually not entitled to. Yeah? So to me, that type of confidentiality is actually very, very well needed. And then I would like to say about storage of data. We all know key populations are actually criminalized. Once this data actually lands on the wrong hands, people and communities can be arrested. So it's how safe is my data? The people who are handling my data, yeah, do they actually know how to protect the key populations? And then lastly, it's on the human rights. Health is a human right for all. And as key populations, we have to ask ourselves, what sort of services do I need in terms of our typologies? If I'm a transgender person, sex worker, persons who use and inject drugs, or an MSM, what is the service package that I need so that I am able to live free? Thank you.
Thank you, Solo. A round of applause for Solo. Solo has underlined the issue of privacy by design, from triage to data protection. Critical fundamental issues as we talk about integration. And now we move to Churchill, representing vulnerable populations. For Churchill, what does access of health services look like for many people in everyday life?
Thank you, Ludfin. Good afternoon, colleagues. So integration is supposed to ensure that nobody is left behind, regardless of who they are in society, as long as they need services. So I'll paint you a picture of a certain sector of society that are vulnerable because of the economic factors. Because due to the economic factors, they are hindered from accessing services. Let's look at fisherfolk, for instance. They move from one landing beach to another in search of health services, in search of the economic, to get the fish. So if they're in a specific facility, they still need to get their medication, right? But when they keep moving, then it becomes hard for them to do that. If you look at trackers, for instance, they are a mobile population. They are always on the move. For instance, if they move across countries and things like that. So even as we're integrating services, we need to think of how we can be able to reach these populations. Let's look at discordant couples, for instance. Most of the time, healthcare facilities are focused on the index client. They forget about the negative partner. What if the negative partner is a lady who is a homemaker? She has got no means of economic stability. She depends on the husband. And then we're having cases of IPV. She's at very high risk of infection, but as a system, we are not looking at that. We also need to look at even the healthcare service providers themselves. If you go to a facility at the ANC and the wife is pregnant and you're discordant, they're looking at you like, how did that happen, So things like this, it hindrances to services. Then there's long queues. And as much as we are seated here, we are comfortable. There are people, because of the way the economy is structured, they live hand to mouth. It's day to day, and this day to day means they have to work every day. Now, if they have to work every day, it means they cannot live a single day out. If they do not go to work today, they will not get the 500 to sustain their family for that day. If they go take care of their health, it means their family will sleep hungry. So they are damned if they do, they are damned if they not. But if we will not sit here and just create hard situations. What we would like to do is also offer solutions. Because if we look at barriers, barriers are man-made, which means we can also unmake them. One of the first things we should do is, even as we are looking at these things, we need to put in the human rights and gender lens so that we can ensure nobody is left behind. It is very important that even as we are working, everybody feels that they are safe. Let me put it, for instance, just service delivery itself. As recipients of care, we would like our service, the services that we receive, to be respectful and confidential. Because if you go into spaces like, let me quote hospitals like Nairobi Hospital, Aga Khan, you're received with courtesy. You're called sir, you know, something like that. In these other ordinary facilities, you're where harakisha, you know, you're pushed. So just a little courtesy. Then we start wondering, did these people go to the same medical school? You know, questions like that. So we just, a little, you know, respect and courtesy in the way services are delivered to us. So for us, health services without barriers would mean that, one, in the way that we have framed our programs, this prevention is taken as, it's looked at in a pedestrian manner. It's a by the way. Prevention is important if we are to completely by 2030 forget about HIV as a public health threat. We must also understand that disease does not give you a warning. If it did, you take care of yourself. So we need to be able to meet these vulnerable populations. I'm telling you, they are on the road, they are moving beach to beach. We need to meet them at their point of need. We need to design our, whether it is integration, so that we are flexible, because if we do not do that, we risk losing them to disease. So finally, what I'd like to say, let us not reinvent the wheel. Let us use what we have. For instance, on our end, we are proposing that we have got trained peer educators, but due to the deprioritization, most of these guys are a wasted resource. Let's find a way to ensure that we can get them information that they can give to their peers, so that, one, they will create demand for health services, but more importantly, they will ensure that their peers are not left behind in terms of service delivery, so that the services that are delivered are accessible and affordable. Thank you.
Thank you, Arumasa, for highlighting the need to design integration that reaches people where they are, because some cannot be reached because of geographies, because of income, and because of other structural barriers that we have talked about. Allow me now to hand it over to Matilda. Matilda, from your experience as a young mentor mother, navigating maternal and HIV services, how does integrated care affect the experiences of women and families?
Okay. Foremost, it is the integrated care has a profound impact on the experiences of women and families, especially at the community level, where mostly the health journey begins. It comes from the community. Now, we get a challenge whereby you have a mother who's coming for medication. At the same time, he has a child who has to be going to undergo a PCR test. At the same time, this mother also has to undergo a family planning. This same mother has to go also for cancer screening. Okay. Then the problem comes here. The TCA are different. When he comes from the medication, she'll be given another TCA. The baby comes for immunization, she'll be given another TCA. When it comes for family planning and cancer screening, another TCA. So integration will be helping our mothers on making sure that this mother comes to have a universal coverage on the medical services, which will be saving the time. It will be saving also the transportation costs. It will be also helping our service providers have that way of making the services in a coordinated way and fragmented system. At the same time, the second thing the integration will be helping is to continuity of the services. It will be improving the continuity and the quality of care. For example, if a pregnant woman is not just seen once, she should also follow up during the delivery, after delivery, the postnatal care, and after the postnatal care, the child health services. It will also help the community promoters, referring and follow-ups families that are less likely to fall through the cracks. That way, it will help us not get the missed opportunities that you have been getting when you are not using the integration. Third, the integrated care makes services more person-centered and respectful. Women are treated holistically, not just for one condition, but as individuals with multiple interconnected needs. This builds trust in the health system and encourages more consistent care-seeking behavior. It also strengthens early detection and prevention. Families benefit when issues like malnutrition, high BPs, or childhood illness are identified early at the household level and managed before they become severe. That is why I've said this journey comes from the community first. Without the help of the CHPs or the community mentor mothers, this journey is likely to fall because we start from there. It is them that they are the first to know what is happening during at the background before they refer the people to the facilities. Then, in instance, integrated care transforms the experience from one of fragmentation and burden to one of continuity, dignity, and support, where the system works around the family, not the other way around. That is all that I can say for now. But I'll also ask to the apologies. I am a mentor mother, and today I'm standing in front of all the people here. It is a pleasure to be standing. It is my first time to attend the summit. But I have an information from all the mentor mothers, including me. We are grateful for your support, for the things that you've done for us. But there are also challenges that you are facing, of which I need to highlight some of them here. Currently, I'm a mentor mother working from the Global Fund. For a few months now, the stipend has been coming late, very late. It has been making the work sometimes to be so hard for us to manage, even our own clients. So with due pleasure, please, the people taking care of us, please, can you please tell us sometimes if why the stipend is just delaying and it is making us, some of us, not me particularly, but I can feel for some of the mentor mothers, my own colleagues who are single parents, complaining. It is making their things to be hard, even to reach to the station where they are working. The fare, everything that they cost them, it has been a hectic. They really need to improve their mothers, to put them from where they have, it is a challenge for a mother who is newly positive to come forward and to encourage that mother and to tell the mother, I'm also HIV positive. This journey is not for you alone. It is for all of us. To encourage that mother, because infections, they're likely, as long as we are trying to eliminate, we are really trying to eliminate the HIV prevention to our mothers. But as much as we are trying, there will also be one or two. So in order to lift our own clients, please, the people who are in charge of that, please, can you please ensure that these things, they come early. Secondly, since it is a stipend, we also like the government to consider even us in attaining us even the higher position, like employing us, so that it moves from a stipend to the salary. Yeah. Then third, sometimes that we are breaking through, we also need the support of the mental or debriefing. Trainings on mental and debriefing. Some of us are really breaking through. It is just that we just go strong in our facilities so that our mothers not to know that you are breaking through, you are lifting. Because if you try to say you're also breaking, these mothers, they say, if this one now is breaking and is the one who started to encourage us, then how will it be? Yeah, now that is the problem. So please, we also need those support trainings. We also need those debriefing. We also need those mental trainings. We also need sometimes the new guidelines that are being implemented. We also need to be part of there so that we can also share our own experiences. Maybe it will help us in straighten more on what to do.
Thank you. Thank you. Thank you. Thank you. Dr. Mulwa, Dr. Bosire, and all in the room, you've heard Matilda well. The last line, the mentor mother, so that they don't break, they need the support to debrief, to be competent enough, so that they hold that mother that has just discovered their HIV status. Thank you so much, Matilda, for your courage and for giving us so much hope that is not yet end. Let me now go to Violet, community health promoter from Mombasa County. As a frontline worker, what stands out to you from the experiences that have been shared today by our colleagues in the panel? Over to you.
Thank you very much, Ludfin. From a frontline worker perspective, it's evident that from these discussions that have been here before, the CHP is the end and start of integration. This is where the health journey begins from. As much as this is happening, I'm particularly struck by how data-driven referrals, digital tools, and coordinated care pathway that is improving efficiency and reducing missed opportunities for care. This is really it is a plus because we are having now in the future our patients won't have to navigate through a fragmented system. However, these successes, they cannot happen without you guys, stakeholders, investing in CHPs. By investing, I mean, this can be through proper training. We have 107,000+ CHPs in Kenya, but if you go back to their bios, the CHPs who have basic community health training modules are very few. And these few are thanks to the partners and donors who come in and say that today I want to train CHPs. And you'll find that, for example, in Kongowea, where we have 60 CHPs, they only deal with around 10 due to resource constraints and some other things that hinder that. We don't have tools to help us deliver this. The commodities that were in the kit, our BP machines are not functioning because we don't have batteries anymore. We have glucometers, but we don't use them because we don't have the RBS strips. Like the weighing machines, they are not functioning. We don't know how they're going to be maintained, because if you address that with your chat, the best she can tell you is, wait, I'll escalate the issue, then I'll get back to you. The getting back to me is not happening. the MOH 100 tools. Yes, we were told that we were going digital, but as a matter of fact, just the last month, we had to do our 514 on paper, hard copy. Another thing, when we do the EACHES thing and refer, when I refer a client to the facility, there is no notification. This system is not connected to the facility that maybe the service delivery point, maybe the HTS, CWC will know that Violet Kibiso has referred a client. And this again leads to these referrals losing on the way. They disappear on the way, either in the hands of the service provider or in the hands of the client, who is the patient, because there is no proper documentation at the facility, there is no proper storage. And at the end, if I have referred clients, and when I'm going to check end month for the effective referrals, and I don't see these referrals at the facility, this simply implies that I didn't refer. You see now the efforts I'm putting back in the communities are going to waste. My colleague has talked about remuneration. In Mombasa, we received 2,000 from the county government, 2,500 from the county government, and national 2,500. But again, this money comes like a thief. No specific time, no specific date, no specific day. You cannot plan for this money. You cannot plan for it. And at sometimes we are forced to dip into our pockets and give a client transport to the health facility. The system is failing us at the facility. The other day we were told, you refer a client and she comes back to you and tell you that nimeambiwa system hazifanyi. She has not even been explained what system is not functioning means and why she cannot receive services. So those dealing with SHA or whatever system that you're putting in place, including the EACHES, let it be effective, let it be sustainable, and let it work for the betterment of HUTCH as CHPs. My colleague has just talked about career progression. I'll talk on that too. I started being a CHP in 2012. Na tulikuwa wengi and there are more who even started before me. Along the way, I've received trainings. Thank you. Along the way, thanks to AMREF and the Ministry of Health, I went to KMTC Nairobi campus and did 2 years community health course. I graduated in 2023, came back as CHP. Even the CHPs who are looking up to me, hata ile motivation ya kuwa wao pia wakasome, imeisha. The political leaders, when they stand in podiums, they emphasize and repeat. If these CHPs go to school, we can absorb them when opportunities arise. Opportunities come in Mombasa County, I apply, but even being considered, just consider shortlist me, nikuja nijitetee kwa panel, nianguke. But you're not even shortlisting me. That is demoralizing, because you also need to be motivated, and that is one action of motivating me as a CHP. Thank you.
Thank you, Vio. Thank you so much for highlighting integration is proven in the last mile. We must know if referrals truly close and if CHPs have the tools to safeguard continuity of care. But also, if CHPs are motivated and valued in this last line. And we have the policymakers in the room. We know that the PS had to handle a very critical agenda, but I think this would have really been beneficial to him as well. But we will document this, and Dr. Mulwa and Dr. Bosire are in the room, so we appreciate that. Now, we've had the lived experiences. We will now invite 2 or 3 focused questions from the room. It doesn't have to be a question, it can be a reflection. And we would like to request our ground rules still stay the same, that we are concise, we are solution-oriented, and we do not repeat what somebody else has said. So, to the room. Anguva TB champion, Maureen Murenga, and Ann O'Carroll. Could somebody help me with the Dr. Laz, please? To Anguva. Anguva is there. We would also like to hear from the policymakers.
Thank you very much, Ludfin, and thank you very much, panelists. Good afternoon. I stand on all protocols observed. My name is Shikoli Stephen Anguva. I coordinate Network of TB Champions in Kenya. Mine is a comment or my just insight from the TB affected communities. We have been speaking about integration since we landed here on Sunday. Unfortunately, in this room, I don't see the head of TB program. Are we integrating only specific area in HIV, or we are supposed to integrate health services? That should be taken to the policymakers. Number two is we know that we need to integrate services, but we need to be ready. The country is not ready. Let me tell you, the country is not ready. For example, today, even I'm an MDR TB patient and I'm integrated to go in outpatient. What are we doing? Exposing mothers, exposing children, exposing people with immunosuppressed to TB, and yet we are talking about dealing with infection. So we need to first of all work out systems to ensure that infection prevention systems are there. Finally, do we have a policy or a framework that is guiding us on this integration? If it is there, I've not seen it. I've looked it online, I've looked it in the ministry, I've not seen it. So do we have a standardized framework that is guiding the country when it comes to integration, so that we know this is what integration means and this is how integration should be done? I would recommend that as a country, we don't rush. Let's not go and tick a box in terms of we did integration, but let's go with it in a phased manner. Let us go and work on it step by step, stepwise. We are not in a hurry. The world is not ending. Integration can be done step by step. Let's learn as we move from maybe county by county. Let us pilot it, and then after that we learn as we continue scaling up the integration. Thank you.
Thank you, Anguva. The next person, Laz, it was, okay, give it over to the lady.
Finally. Hi, everyone.
Hi.
My name is Josephine Odhiambo from Y Plus Kenya. I have a question and a comment. My first question is to any of the panelists. We've talked about issues around safety, and my biggest concern is data safety, and now we are talking about integrating AI into the conversation. So from your perspectives, is AI into the health system? Is it something we need to welcome, or is it another problem that we'll need to talk about? On to what she said, I think it's important for us to prioritize psychological debriefs for community health promoters, because they're listening to a lot of stories. Even psychologists have psychological debriefs. So why are we not prioritizing psychological debriefs for community health promoters?
Thank you. Let's have it for Anne. I'm just trying to be balanced as much as possible so that I don't concentrate on one segment of the room. And O'Carroll, concise, to the point, and offer solutions. Thank you.
Thank you to the panelists. Allow me to arrive on the protocol that has already been observed. My name is Ann O'Carroll from the Kenya Network of Positive Teachers. And my question and a solution at the same time is to the mentor mother and the CHP. At the coast, we really have a lot of teenage pregnancies and dropout from schools. My concern is, how are you intending, or how are you working with the Ministry of Education as far as return to school a policy is being taken care of for these girls that once they give birth, they get back to school? And how are you supporting them in your own small way? Thank you.
Okay. Let's just have the responses. Some of them will be taken by our government leadership in the room, but let me give it over to my panelists first. The first question was the issue of AI. Chero, will you want to take that? and the issue of safety. It was designed around safety. And then the next question is to Vio. Is it Violet or Matilda taking it? Violet, on the issue of CHP. And then the questions that were specifically on whether we have a framework guiding the conversations around integration, that, and why the TB program is not part of the conversation. I think that I'll hand it over to Dr. Mulwa, since he's in the room. And then I'll give another round and we'll close it because we need to go to the community villages. Over to you.
Thank you so much, Ludwin, and to Josephine. Najanta Mona Kotentia Blue, but to also just answer the question. One is that we're in an era where digital health could actually save us, including artificial intelligence. Whether in health, we've seen telemedicine as an option that is actually working if properly utilized and integrated in our health system, whether it's data collection, real-time data actually, you know, whether it is supporting young people to be able to access comprehensive information that is correct on reproductive health and HIV and all health matters. So it does play a huge role, but the most important thing is that we ethically utilize it and make sure it has all the safeguards it requires to be able to protect our data and our information, and that communities are also digitally literate to be able to know how to properly utilize it. AI is not ours, but we can make use of it for sure.
Thank you, Chero. Over to you, Violet, the issue of linking with the Minister of Education as CHPs as you touch the lives of the clients in the communities. Over.
Thank you so much for that question. As a CHP, my main and very important role is to identify and refer. So again, before I was a girl mentor, so I have knowledge. I am an IPTG facilitator, so I also do some group counseling and therapy sessions. We work closely with the schools. I do mentorship sessions in school, but now that is not as a CHP because, again, I said these trainings, when they come, because it is donor funded or partner funded, they pick few to be trained. Not all CHPs get the privileges to get all these things that happen around. So when I get a case of a teenage pregnancy, we should first understand that where there is a teenage pregnancy, that is defilement. So there are a lot of bodies that need to be involved. You link this teenage to DCS, you link to the facility because they might be needing care as well, and you also link to the police. Though there are challenges again, I've had cases where you link and at the end, even the families, they come to you and like, ni wewe unataka ashikwe, sisi hatutaki. Probably because they have been told there is 30,000 somewhere, we can give you, then this story dies like that. And police, sometimes, they are even the ones initiating these negotiations with the victims. So the best we do as CHPs is refer and give some little psychosocial support that we have, then link to the counselors and other relevant departments. Thank you.
I know that. Thank you so much, Vio. Thank you for the responses. There are some specific questions that are to our leadership in the room, Dr. Mulwa and Bosire. I think we hold it there, Angie, and we finish with the questions. Then Dr. Mulwa can then come and wrap the questions that are being... Dr. Mulwa, I'm requesting that you hold on until we finish, and then when we finish the panel, you can come and wrap every question that is targeted at government. So I'll give two more, Maureen Murenga, and persons with disability. Okay, what's that? They have a question. Okay. Sorry that I'm not looking this side. So we'll have Maureen. Then Dr. Laz, you will give. Yes. Remember we talked about rights-based in the morning. So we are trying to balance rights as much as possible. Then we will go to this side. And then we have a last question. So there are only three, and then we have Dr. Mulwa come in. So when you say here, who is it? It can only be one person. Rose Kasiba. Okay. So we have Maureen Murenga. Then, is it Benson talking? Or okay, then we have this side. Then we have Kasiba. We finish with Lawyer Katindi, and then we go back to our one question panel. Colleagues, communities, please, we need to handle this, because if we overstay here, our villages are affected. Maureen, please. Dr. Laz, come. Maureen, please proceed. Time.
Okay. Let's go. So I'll talk about persons with disabilities, how we'll make sure that we integrate them. For example, persons with disabilities who are women, like now the lady who spoke, she said that like in the facilities, when you're doing integration, sometimes they tell you that you go to different sections to get services, different points. So I think if we have one service point with all services available there for the health, so that we can have a holistic health approach and we get solutions to everything that we need at one service point. Because you see sometimes this specific doctor, maybe you are explaining that you have someone with HIV, then you explain your situation, they give you the medication. At the same time, the staff, we will need to make sure that the staff there knows some sign language so that they can also integrate the deaf people and they can be able to support them properly. So if everything happened there and the health sector, the service point is inclusive, when the facility is inclusive, then integration will happen. Because you know, the deaf people, they are not stupid, they are very clever, so we need to just integrate them at the hospital, at the health sector, and make sure that all the services are at one service point. Because many times, persons with disabilities have really suffered because of the barriers that are there. Sometimes they are ignored because of communication barriers, and it really pains. So it is very good to get the doctors, nurses, and all the staff in the facilities know some sign language and also have interpreters there. That way they will understand persons with disabilities. Thank you.
Thank you so much. Disability competency is very critical in the integration agenda. We appreciate. Maureen, to the point and the solution. Thank you.
Thank you very much. I'll speak. I support what the mentor mother said, and I'll also talk about what we need actually to end vertical transmission. The president promised us that we are ending vertical transmission next year, but the numbers are going up instead of down. So what do we do to ensure that we are ending vertical transmission next year? I don't think we have given this easy to handle epidemic the resources and the attention it requires. I always say that we need three things. Number one, we need an empowered woman. These children are in the hands or in the wombs of women living with HIV. How are we empowering women living with HIV to be able to understand what to do to protect their children from HIV? We also need a working health system. In the past, you have blocked us by asking that we bring our partners. Now you are blocking us by asking that we pay a full year of SHA. So the health system is always having a barrier for women who want to have HIV-free children. And the third one, we need, what we need are skilled healthcare providers who have the knowledge and understand that even women can have what we call postpartum depression. Most of the healthcare providers in the antenatal clinics do not read the room. So when you go there, you're being read for a riot act and you're not being supported. And finally, we really understand that the mentor mothers would want to be in the ACADA of government under the CHPs, but we know CHPs define communities geographically. In the other hand, we define communities as populations, as people living with HIV, key populations, drug users, men who have sex with men. So the geographic and the population definition of communities is different. And then you know that some of us don't take care where we stay. Mental mothers live around, CHPs work around 100 households. We take care in Nairobi when we live in Kisumu because of various reasons or complicated reasons. So I think we need to really think through some of these recommendations. Thank you.
Thank you so much, Maureen. Dr. Mulu, I think the issues, some of them are a bit complex, but I think we will all navigate together. I will not repeat them because they are coming in as recommendations. Rosemary Kasiva, it's your turn. Where's the mic? Dr. Laz, you are my support today.
So good morning or good afternoon, and my name is Rosemary Kasiva, better known as Mama Rosa by the key population community. I stand here on behalf of them. And I want to begin by reminding all of us that as key population, we are a criminalized population, right? So when you're talking of integration, we need to be cognizant of that point. It's really been a hard sell to our communities about integrating them to public healthcare facilities, for lack of a better word, and allow us to speak because we represent the communities we are talking about. Now, I'm not trying to underscore the rest of us from other populations, but just remember, we are used to our own diocese, where we've been accessing services. When you look at me, I'm not a young girl, but for the last 20 years, I've been going to a diocese that is exceptionally kept for the key population. And that's what has kept me going on and on and on. Now, here we are not against integration, but can you please allow us to define and design how this integration should look like? And even the wording. I know we've had several meetings talking about SOPs, talking about transitioning. Now, most of us were being led by emotions. I think the die has been cast. It's time we sat down and defined how best we can be able to reach us and ensure that the gains we have made are not watered down. Some of us are used to accessing services in our hotspots, whereby we have outreaches, we have satellite clinics being brought to where we are. And now, not only has that come to an end, but even our dioceses are being forced to close down. We have a number of models that we have defined to NASCOP at the Ministry of Health, that we can explore all these models and see which one fits who and at what county. Why are we all being forced to go with one model of being integrated into facilities, yet we have been able to offer solutions of as many as possible? We want services that are being offered to us to be non-judgmental. We don't want to come to a place and I'm dressed the way I'm dressed and they're like, why is this woman dressed that way? I don't want to go to a place because I am having drugs and I'm having, what do you call them, arosto, and they tell us we cannot be able to serve you until when you sober up. Kindly have dialogue with us. That's all we are asking. And when we are having this dialogue, remember, we key population, in as far as the Kenyan law and constitution is concerned, we are a criminalized population. So therefore, we face double stigma and double everything for everyone who's spoken here. Thank you so much.
Thank you, Mama Rosa. Only, we need to get back with one question to the panelists. Kindly be brief. Philip, and then Katindi, that is it. Philip, then Katindi, and I go back to my panelists to give us just one last proposal on what they should see as a proper integrated care. Philip, please.
Thank you very much, panelists and the organizers of the event. I'm Philip Nyakwana, the chair of the non-state actors. I think I've listened since Monday, since the event started, and there are a lot of conversations on system integrations, There are also a lot of conversations on issues around implementation efficiencies and such kind of things. But we are not having conversation on the structural issues, because people don't get there if we cannot break the barriers that stop people from accessing services. You can have stocks of drugs and all that, but people will still not access them. But in our conversation here, we are not talking of how, including how are we going to deal with some laws that HAPCA is saying something, the other side of law is criminalizing, and the other one is putting people at danger. And we are talking of integration. We may not achieve much, so we need to. Then my other point is, where is the space for communities in the integration agenda? Because even if you take stock in this room, you'll find that more than 3/4 of people here are doctors. And they will talk medical terms. But you say community at the center. So which center or whose center are they, if they are not at the center of the conversation? So we also need to find a way, how do we create space for communities to be on the table as we have the conversation of integration? My last point is about, as we integrate, I thought in this forum, we'll be taking stock that since the country started the integration conversation, this is where we are. So in terms of our next step, this is our short-term plan, mid-term plan, long-term plan, and our indicators that we can track. Otherwise, the way it is, we might come here next year and still find ourselves talking of the same things without direction. So I listened to the Uganda lady, and they have a very clear direction, including meeting, having a clear framework, people playing their roles and how they do it. So it's my wish, it is my prayer that we have a clear plan. If it may not come out of here, as communities, we are ready when called upon to be part of this conversation. Thank you.
Thank you very much. Katindi, I think Katindi will be our last. Then I will take it back to the panelists. And then Dr. Mula, you'll allow us to just close, then you can come to really wrap it up because of the policy-related issues. Katindi.
Thank you so much, Ludwig. I just want to commend the conversations we've had from Monday. We have no doubt that there is a commitment towards service delivery integration. However, if we are going to talk about barriers, and I think you've heard from the two speakers who've just spoken before me, we have to be bold enough to have conversations about barriers that we are not willing to confront. And those are legal barriers. Legal barriers is not just about key populations. Legal barriers is about that HIV positive mother who risks criminalization when her child becomes HIV infected. Legal barriers is about a youth who is trying to access services where the Children's Act as amended has compelled parental informed consent. Legal barriers is about a HAPCA bill, a HAPCA review process that is stuck with no commitment to advance the efforts that have been made. So I think when we are talking about commitment, and this is a challenge for our leadership at NASCOP, at NSDCC, can we hear more commitment towards addressing legal barriers that shape whether or not people will be able to access barriers?
Thank you so much. Thank you to the audience. You've proposed solutions. So I will now turn back to my panelists and thank them. But before that, I would like now to ask you, the panelists, just in 20 seconds, what would health without barriers look like in everyday life for the communities that you represent? Patricia.
If we are truly building a system of health without barriers, then integration must not only connect services, it must remove the barriers. We must ask who has to be protected, what supportive mechanisms are needed, and how will this be implemented and sustained?
For me, it is two things joined together. One, it is a system, an integrated system, designed, resourced to be able to be responsive to the diverse, unique needs of adolescents and young people and all communities in our diversities, a system that is able to meet us at our points of need. But number two, it is a system that is intentionally designed by us, the end users of these services.
Mine, in terms of barriers, it is the breaking down of laws that actually criminalize us, looking or facing it headstrong, because we know we have the legal barriers that affect key populations in accessing services. Thank you.
Thank you. So from my end, I would say that integration can only work if we consider the economic factors that hinder access to services and ensure that we can dismantle those. Thank you.
Mine is to say that it should make people be bold and strong and come out to access the services well without fear.
Health without barriers for the communities I represent will simply mean that care is accessible, continuous, truly people-centered.
Thank you. Thank you. A round of applause from my panelists. Thank you, Patricia, Jerop, Solo, Churchill, Matilda, and Vio for really surfacing the issues. I think they just touched a tip of the iceberg. I will try to summarize and then hand it over to the policymakers. And the policymakers in the room, I'll hand it over to our own professor, who we know, who has worked with the communities, who has ensured that the communities who decided to have HIV negative babies did have them. So I'll give the mic to you, then you can hand it over to Dr. Bosire and Dr. Mulwa. So to our audience, thank you so much for engaging the panelists. We can all attest that the issues that they have surfaced are real. We set out today to ask a simple but important question: is integration real where it matters most in people's lives? And by placing lived experiences, by centering, we heard what works, what fails, and they proposed to us what must change. So a right-based integrated health system is not judged so much by the policies, the guidelines, however much those are important as well, and they're very valuable indeed because they shape the discussions. But what actually this panel has shown us today is what actually will be important is care that is available, accessible, acceptable, and of quality. And as we heard, delivered with dignity, privacy, and without discrimination. Our challenge today now is to turn today's insights into accountable action. Number one, there are only three, I'm summarizing the only three what I had. Design for real life. Don't just design in terms of systems. Services must meet people where they are, not force people to fit the system. Number two, protect dignity and trust. Integration only works if people feel safe. That means privacy by design, zero discrimination from every provider, and feedback and grievance system that actually responds. And number three, sustain what works. To deliver continuity and participation, we must invest in community-led responses, ensure that we embed community voices as we move forward with the integration conversation. Let them not put them on the sides, but let them be very intentionally involved. Meaningful participation means that we are intentional, we are structured, and we can measure that communities indeed are involved. So Dr. Mulwa, thank you so much for the opportunity and helping us to have this conversation. We would now like it to hand it over to the policymakers in the room, and I now hand it over to our own Professor Ndwati. A round of applause, but as Professor Ndwati comes, could we have the photographer to really take the photographs of the panelists? Here you go. She'll come over now. You can join us.
I've asked very kindly to be allowed to say this before going to being handed back to the government. And I want to highlight maybe two things. The first is the issue of supporting the councillors. Patricia here is my friend from many years ago. She was the person who was the backbone of counseling the first cohort of people being tested and testing positive with HIV. And there are many people who are alive and grandparents because of that. There are new methods of counseling. Trauma-informed cognitive behavioral therapy is effective in treating anxiety, depression, and post-traumatic stress disorders. Let us offer this training to the community so that it is not something that you come to hospital for. It's something when we have your chama or you are meeting with your girlfriends or your boyfriends or whoever, that you support each other. The second thing is, and this is to the government, there's no big city that doesn't have a swap clinic. The first so-called swap clinic in the language of then was here in Portrit, and the other one was Majengo in Nairobi. You cannot control STIs if you don't have a facility that focuses on people who are, focuses to individuals who are in that space. The first property owners in the city of Nairobi, African property owners, were the women who are sex workers. The history is very clear. So it's a long history of it. So those clinics that were started and were developed further by Elizabeth Gogi, and now the swap clinics, that's a model that we need to multiply in every place where you have a large cluster of people. And in countries where there's development, and countries that have contained the epidemic like Thailand and others, this is funded by the Exchequer. It's part of what the city health services are providing. The other clinic we must commit to having is one that addresses people who are IV drug users. Needle exchange programs are the key to reducing HIV transmission among IV drug users. This is work, very well documented research work, and it works. And in cities, for example, like the city of Seattle, the King County Health Department, that is like the Kajo of the city, is the one that provides those services. So we must commit that in those clinics, we provide an integrated service when you we already provide methadone out of the Mathare clinic and around at that Mathare area. Once you start providing methadone, people start having families, and their children are exposed to these drugs. Dr. Bocha did a study up here in Nairobi and shows what happens. We must have programs. That's what it means to be a responsive government to the needs of the people. The rest of us will hustle in the public sector, clinics or wherever, but there are people who are so vulnerable that they need care. Now, my last comment is to the young people and to their parents and to their grandparents. The most important thing for a teenager is to defer sexual activity. There's nothing beautiful about sex as a teenager. One, it sets you up for intimate partner violence. The data from this coastal region, Kilifi here, is very clear. The baby of the teenage mom is the most vulnerable. They come in as preterms. They have the complications of long-term problems that will lead even to mental retardation. And when you have a baby and you leave that baby to your mother, at your grandmother looking after that baby, you begin a lifelong conflict with your own mother. You know, you can defer sexual activity to when you're a grown-up. At that time, you're making the decisions and you're taking care of yourself. The SDGs talked about 12 years of basic education. The data is very clear, not just Kenyan data, European data, data from the UK, Italy, America. A person who does not complete 12 years of education is almost guaranteed to live a life of poverty where you have no control of what's happening to your life. So I appeal to the young people, just defer it. It will be there in the right time and with the right person. And for the parents, please, for the parents and the grandparents, please protect your young people. Please provide appropriate information. They are our future. And we as the health sector, let us not be afraid to say what is the right thing. What are the facts?
I am a student of Professor Duarte from medical school, and now you can tell the caliber of lessons that I learned. I think when she spoke, I was like, and what will I say after what she has spoken? Of course, putting things from academic perspective, what has been done, in terms of what we need to prioritize in terms of available data, which puts our thoughts into perspective as we think about programming. I think easily, the last session is the session I've sat down the most from Sunday because of the interest and the honest conversations that we need to have as government leaders and communities. What has come out across is we have done a lot, and the PS provoked our thoughts in terms of what the reality is that we are going through. But as I have maintained, everything that we do, disruptive as it must be, uncomfortable as it must be, we must account for continuity of services for each and every member of our community. I think that has been a clear message from me, especially, and from the ministry, from the day that we have had disruption or changes in the global and our health financing landscape. And I will still maintain the same. That one, we have health is a fundamental right for all of us. Whether key population, whether Dr. Mulwa, health is a fundamental right. And that therefore means provision of health services to any citizen of this republic is not based on whether I choose to or not, whether there is money or not. And that is the conversation that we wanted to have. We also have a reality that we must deal with, that first, as national government, we have a constitutional responsibility assigned to us by the 4th schedule of the Constitution of Kenya. We also have county governments equally with responsibilities assigned by the 4th schedule of the Constitution of Kenya. I spent my youth in the county government of Makueni as the CEC for health, and counties are responsible for implementation or delivery of services, except level 6 services, which are referral services. And every county has its own uniqueness in terms of resource, population, size, and everything. And what Professor has said is we have urban counties, we have rural counties, we have counties where we have a significant population of AKPs. The response in Garissa, in Mandera, in Turkana will not be the same as Kisumu, Nairobi, and Mombasa. It's important, and that's why the counties are here to have conversations for counties to design health systems that serve their populations. There's also another reality that there are counties that also have, do I want to call it migratory or shifting population? Nairobi has easily 2 million people that don't reside in Nairobi every day. Those people reside in Machakos, reside in Kajiado, reside in... So we have counties that are bedrooms, and we also have counties that are production, Nairobi being one of them. So the programming for Nairobi should address the peculiarities of the city. The burden of people who inject drugs, for example, is in major cities. This is not to say that it's not happening in those other counties, but we are saying where there is substantial numbers, then therefore the health programming, the health system of these counties should be able to address that. I wish Dr. Ganda was here so that we also have the county perspectives. And that means when we are doing health prioritization in our counties should be geared toward addressing the health needs of the population that you serve. I think having said that, there are specific administrative, I will call them, issues that have been raised in terms of mentor mothers. I think I have picked the delay. That's an issue that was raised to me earlier on this week. I don't know where the system, the system is not working as efficient as it should, but we should be able to handle that when we get back to Nairobi. Our intention, and I think from where we sit, by the 20th of every month, we have already processed, especially the Global funded mentor mother programs, and we will want to know where the system is not working as efficient as we want it to work, and ensure that those issues are addressed. A very important issue that has come about taking care of the mental health of the people, of the community health promoters, and also our mentor mothers. That's something that I think we pick from these discussions. The assurance that I want to give communities, because the issue of diocese has been discussed. I will summarize it this way. We need to sit down and have conversations on how to structure our service delivery mechanisms. Outreaches have happened since time immemorial in the health sector. Whatever model we choose, it will be a model that we can afford, realizing that the diocese that we have run over the last 20 years or so have been externally funded, and the funding may not be there. But we must reflect and ask ourselves, how do we transform these diocese to continue offering the services that we are available within the available resources, or how do we transform them to be able to continue serving the population that they need to serve, and as well be affordable to the county government, because that is a responsibility of county. So we need to have conversations. And I want to ask the Nairobi County Health Team, Dr. Ngunu is here. I've seen a big contingent of teams from Nairobi, Mombasa, Kisumu, and Nakuru counties. Those are the counties that are most affected by this. Makueni is also part of that because of the corridor. Machakos, yes, Machakos, there's also those services. We need to have these counties have a conversation and sit down and structure together. The national government can do the stewardship to ensure that services continue and serve the population. Of course, there is the issues of criminalization, all those things that we are saying, but we also must realize, I'm not saying we are changing. We must realize that we may not have the resources to do what we were doing before, but we must also have the courage to continue with the services that serve the population in the best way that is possible. With those many remarks, I want to invite Douglas to maybe make resources. There are specific issues, policy issues that have been raised about legal barriers, which we'll need to sit down and work together. And that is essentially the purpose of this summit, so that we are able to flag what are the areas that require attention going forward as we think about integration of services. Thank you very much.
A better round of applause for Dr. Muller, please. He's the one who has coordinated us all to be here, so indeed it deserves that better round of applause. Now, let me just begin with where Dr. Muller left, the legal barriers. Ladies and gentlemen, there are countries in this part of Africa, Eastern Africa, where you cannot openly parade and stand up and speak before people and tell the people that you belong to the group of men who have sex with men. True or false? There are countries here in East Africa where you cannot go and announce that you are a female sex worker. True or not true? Same thing to PWID. What we are saying, the mere fact that we are discussing about these issues today shows the progressivity of the Constitution of Kenya, which has enabled us as government recognizing the fact that there are still sections of the Penal Code which criminalize some of these acts. But riding on the principles, on the tenets of the Constitution of 2010, we are still able to promote and offer services and advocate for services for all groups of people. So that we must appreciate that there is some legal leeway that has been given to us, courtesy of the Constitution, that we are riding on. We are making progress. We might not be there 100%. That progress, but the fact is progress is being made by Kenya when we gather like this and discuss these issues openly. About the statutes and the other laws and pieces of legislation to decriminalize, this is a function. One of the functions that we have as NSDC is advocacy. And even not only at the Kenyan level, but at the global level. We are advocating day by day on the removal of these criminality aspects that then make populations hide behind the curtain or go under the carpet, such that they not receive services, and we'll see a proliferation of new HIV infections. So that with the communities of, especially the KP communities, we are well aligned and we are well aware that we must fight this together. We must progress together. Number two is the issue of community involvement. Honestly, I think, Philip, there you are unfair to us a bit, because Mulu and myself and other groups and partners, over the last 2 weeks, we have not slept, trying to mobilize savings from all corners to make sure that we facilitate at least a significant number of communities to be here for this conversation. And some of those whom we have supported are here in this room. And for me, one of my bosses is here. The director of the board of NSDCC, Ruth Bungei. Can you stand up so that you can be acknowledged? Can you clap for this lady? Because they are the ones who allow me to break budgets in between the year to accommodate issues which we did not plan for initially. So when she sits here and she thinks that we did not meaningfully bring and engage communities, she'll go back to the board and take me to task when I'm making a board report on my financial statements and say, you did not spend money on communities. Yeah, this money you ate it. You see what I'm saying? So we might not be, again, optimally involving ourselves, but we are making those baby steps. We are making those deliberate and intentional efforts to make sure that we do not walk alone. Even in our policies, in our frameworks, when we are developing them, we try and involve communities. And we know it is a progress, it's a process, it's not an event. The other one, under the issue of, you know, when Violet was speaking, and the mentor mother here, I've also been in that space where Mula talked about. But Mula and I were CEC members in the county governments. And surprisingly, we were leaders of the leadership of CECs. He was the chair, I was the secretary general. And we served at the same time. So there are elements that have changed in the counties, and CASCOs who are here, and directors who are here, and CEC members who are here, and I hope Dr. Ganda was here. There are low-lying fruits that we can actually use to support these CHPs and these community actors at the county level. During our time, we never used to have what we call Facility Financing Improvement Fund, FIF. FIF was scrapped in the year 2013. When counties came into place, they said Article 149 of the Constitution requires that all the funds that are collected by the counties are deposited or they are collected through what we call the county revenue fund. So even what the hospitals were collecting as user fee used to go to the county revenue fund. Getting that money back to the facility was almost near impossible because the counties, the governors needed to show brick and mortar. They needed to buy CT scans. They needed to build hospitals. They needed to build roads for their re-election. But now, under the presidency of His Excellency William Samoei Ruto, we had the Facility Improvement Fund being passed. The FIF was passed. And it makes it mandatory that the resources that are collected at the facility level, be it level 2, be it level 3, are actually retained within that facility for the purpose of offsetting the costs that are incurred in service delivery and also to promote primary health care. Now, facilities that were getting as less as 100,000 now are getting 2 million shillings from share reimbursements. And the CASCOs who are here can bear me witness. Why don't we use some of those some of these resources to even buy batteries for that blood pressure monitor for the CHP? Why don't we use it to replenish the glucose sticks stocks for the CHP so that the CHPs do not come here and say they cannot use the blood pressure monitors they have because of lack of batteries? So there are resources also that we can tap on, that we can leverage as we move towards self-reliance, as we move towards domestic resource mobilization. It's at two levels, not only at the national, but also the county level. So for me, very thought-provoking discussions, but they must continue in the village groups that we go to after this. So thank you very much, Dr. Mulu, and God bless you, Asante.
Maybe before Laz comes back, to confirm, the TB program is here. The director for TB program is here. TB program has representatives in this. The TB community is here. So in terms of the ministry, counties, we are well represented in that because there was a specific ask on the TB program. The head of program may not be here, but the PS responsible also sent someone to be in this summit. Thank you.
All right. So on that note, I'm going to ask Steve Anguva, who is a community TB community champion, to also confirm that TB program is here to appreciate Ludfin, the entire panel, Dr. Mulwa and Dr. Bosire from NSCC. Steve.
Good. The TB affected, I can confirm. For the government, I can't confirm. So let us appreciate the panelists and all the people that have presented in the morning. So integration is about moving wheel by wheel. It's not automatic. So I'm going to be moving the wheel as you clap, as we increase. So let us move. Good. Thank you. Let us integrate step by step.
Thank you, Steve, the innovation. So finally, lunch is here. It's been a very long morning, but you can agree with me that you have had very fruitful discussions. So before we break for lunch, we are going to give direction on the afternoon sessions. So I'm going to now invite Dr. Ashiono to give direction on the afternoon breakout sessions. Dr. Ashiono.
Thanks, Dr. Laz. And in 1 minute, I'd like to just give us direction for the afternoon session, which should have taken place this morning, but because of the very many discussions that were ongoing, there was a bit of a delay. So in the afternoon, we'll pick up from the panel that was here discussing the communities. They've brought out different aspects. We've heard from Solomon, we've heard from the AYPs, we've heard from the VPs, and the Patricia and team representing the different communities. So we are going to have 4 community villages, with the first community being the one for the NCDs and aging, and it's going to be in Arabuko 1. Please take note. The slide, yeah, it's projected there. So the NCDs, aging, and AHD is going to be in Arabuko 1. And then we have the AYPs. AYPs are going to remain in this room, and we have them remaining here because they need their sound system here and to be able to shake a bit. So AYP team will remain here. And by that, I don't mean the AYPs or the NCDs only. We are all going to break out in those rooms. Then we have the KP, and the KP team and all those who are joining the KP community village are going to be in Arabuko 2. And lastly, we'll have the vulnerable population who are going to be in the Shima, which is just next to the registration desk on the right side. So we'll have lunch, and after lunch, kindly let us all join the different sessions. Let us not delay. As soon as we are done with lunch, once Laz guides us on the time, let us be able to go straight to the rooms and be able to continue actively involving the community, listening to them, listening to what they have, and being able to contribute to the discussions they're having. Thank you so much.
All right. So we are going to have an accelerated lunch, yeah, because of time. So we are only going to allow 45 minutes for lunch. Mukule haraka haraka. So by that means that by 2:10, please be in your rooms. And we are asking the moderators for the rooms to ensure that the session starts at exactly 2:10 for only 1 hour. And then at 3:10, we are all